ICB. Welcome to members of the public, some of whom are here, some of whom are online. Good to see you here. Just to remind you, this is an old script. I apologise. This is a meeting in public and not a public meeting, although we do have some questions from the public we'll be answering later. I've got apologies from Ben Anderson, Shirley Kirkland, Christine Joy is on Teams because she's not feeling great. Damien Allen said he ought to be here. He hopes to be here in presence, but he might be an hour and a half late. Okay, declarations of interest, anything new to report? Moira?
I think I've probably done this already, but just on item 14, and the independent chair.
Thank you. We'll note that. Thank you very much. Minutes of the meeting on the 3rd of January. David, I understand you had a slight amendment.
Yeah, please. So it's on page 15, it's the second paragraph.
Yep.
It said 2 independent death reports which occurred in December 2023, but it should have read 2 coroners, regulation 28, prevention from death care provided in November. James got that addition,
Okay.
that correction. So
We'll amend the minutes accordingly. Thank you, David. Any other amendments?
Yes, sorry, I don't know if it's an amendment, but under the section of 524, the patient stories, I think it's worth noting that they're anonymised, because I don't think the section says,
Okay.
it says patient stories, but they're anonymised.
They were anonymised. You're right. Thank you for that. And they were. Okay. Thank you very much. I'll take that as agreement to the minutes. Action log. I know we had an update. Is Christine updating us? Christine, you updating us on quality, diversity, inclusion objectives? Christine, Joy, you there? You were a minute ago.
Just gone down this.
Yeah, I know.
For some reason she's having problems.
Okay.
Thank you. Sorry, I am here. I was muted. Somebody muted me. I couldn't unmute myself. So thank you. Thanks, Chair. We had an action for everybody in the board to have equality, diversity and inclusion objectives. I'm really pleased to report that we have those objectives in now from pretty much absolutely everybody, and that includes partner members, non-executives, associates and executive members, and they cover a really broad range of focus for us as a board. So Piers, I think we're making good progress on those.
Okay, thanks. Thank you, Christine. Anything else on the action log? Okay, agenda item 5, storytelling, NHS dentistry, which of course has been a subject of a lot of interest nationally recently. Anthony, do you want to do some introduction for me?
Yeah, thank you, Chair. Morning, everybody. It's great to have a dental and oral health focus at the board this month. Members will know that the ICB has taken on the mission responsibility for dental since April of last year. And through this patient story in our dental plan later on in the agenda, we want to update and discuss with the board some of the work that we are doing to improve access, quality and patient experience in dentistry for our South Yorkshire residents. If I could first introduce some colleagues, please, Piers, or ask them to introduce themselves.
Debbie Stogan, I'm the dental programme lead for dental in South. I am Sarah Robertson. I'm a consultant in dental public health, and I support South Yorkshire ICB around the commissioning of dental services, but also support the local authorities in South Yorkshire around the commissioning of oral health improvement programmes.
Welcome, Andy.
Hi, everybody. I'm Andy Hobson. I'm Deputy Director for Dental Commissioning, working across the 3 Yorkshire ICBs.
Thank you, and available to answer any questions on dentistry. So as members will be aware, access to dental services nationally is a hot topic for our patients and our public. Later, we'll be referring to the latest National Dental Recovery Plan, which was published last month, and our local work in terms of responding to this. But access can be sometimes particularly difficult for some of our most vulnerable members of society. And today's patient story is a testimonial, really, of one of our homeless dental schemes that we have introduced in Doncaster with our charitable organisations and our dental providers. And we have a similar scheme in Sheffield, and we are evaluating further rollout of this across South Yorkshire. You'll be hearing from a chap called Darren who has benefited from this scheme. And what particularly comes across is when we talk about oral health, actually the knock-on effects that pain can have to mental health, to well-being, employability, etc., is really marked. Anyway, I'll not spoil the story any longer, so we'll hand over to Darren and the dental teams involved.
It's always been a big sticking point, trying to access dentists for our customers. So when we first received all the information about this new pilot scheme, I was really keen. It's something that I knew would make a really big difference for us, especially in terms of making it easier to refer people in for the work that they might need.
So the pilot, we started speaking with NHS England, the ICB, in November. They wanted to pilot the access for vulnerable homeless residents in Doncaster. We had our first successful clinic on the 2nd of January. That were fully booked. We currently do it one afternoon a week, and Darren was one of our first patients, so he's been with us since day one.
It first started when I was under influence of drinking drugs and alcohol, and obviously that's played an impact on my teeth. I went through my detox, that was last January, so 13 months ago, and then just ended up with toothache and all that stuff, so ended up for them to get me an appointment, and we're struggling. Basically, struggling to get into a dentist because there's no places anywhere. Phoning about, getting refused, or people come for me. And then my support worker at Garden House, they heard about this place and got me an appointment, and then that's where I started my treatment in January.
We worked to a model that were provided in West Yorkshire. We adapted that here. The referral system didn't work initially. The charities were a little bit unsure of the process, and what we found was we altered it around, so rather than a phone call, they emailed me directly. I got the information and arranged appointments for the patients, and we found that it's working.
I can just email straight over, provide the names, the date of birth of the customers that we want to refer through, and then they have took it from there. They contact our customers, and then they've been booked in, and it's really been as seamless as that.
The patients at the first appointment with the support worker, and on the whole they're very nervous, they are very anxious, a lot of them, about treatment. For these people it's all about access, improving their oral health, and what that then leads to for them.
Obviously I'm wanting to better myself, and anxiety and depression is one of the main things that's stopped me doing stuff and things, and then me having my teeth done, it's boosted my confidence because they've taken me ugly teeth out and being able to smile without embarrassment, and I feel great.
It's worked really well. Sometimes if the journey for that customer with us is only short term, we might not have actually got to that point of ever getting them registered with a dentist if there's not one available. Then we just have to give them the tools of how they can try and do that out in the community themselves. But it's been nice to be able to see that journey for somebody to actually have received that treatment while they're with us.
Okay, so that was just a short sort of vignette really of an example of the scheme that we're running. I mean, I found it quite heartening. The comments about being able to smile without embarrassment and how that's allowed Darren to start progressing with his life. I mean, Debbie, just an update on Darren.
This is just the first part of his accessing to treatment. Speaking to the side service at Garden House, this chap is actually still in treatment. He's going to end up being fitted with dentist, so that'll actually fill his mouth out. It's quite sunken at the minute, and that's really going to boost his confidence. He's really positive, he's really confident about moving forward with this. He's started driving lessons, he's looking for employment, and really this is, even though you might think it's just about teeth and dental, this is going to change his life.
So you'll see from the plan later on that this is one scheme that we really want to continue, and if anything, actually, expand and roll out to other parts of South Yorkshire. And it's just one part of the improvements in access for the whole of our residents that we want to focus our efforts on. But I just want to open it up really to any questions or comments.
Thanks. Lee, what else people want to raise? Lee.
Yeah, in a previous life, being responsible for homelessness services, I could really associate with that gentleman's journey, I think, and never quite understand the trauma that people actually find themselves on the streets or difficulties facing life. And actually just hearing that story and about the difference that that's made for him and that boosting of that confidence, and just appreciating how difficult it is for people thinking that sort of situation to generally access services. So the way that we try to make that simple and easy and make people confident to take that first step through the door with support from the sort of support work, it's just really good to hear. Thank you for that.
I think the thing is that the patients are being supported by a chaperone to attend the appointment, so that's helping them with that initial step, but also the dental service is taking them where they're at in life as well. So it may be that at that point they just want the most urgent thing sorted, but for others they want everything sorted. So for Darren, he's going to have a denture that will, obviously improve his job prospects, all sorts of things in life. So he's taking them where they are at in life as well.
Moira.
Yeah, I mean, really great story. I mean, I'm just wondering, there are a lot of people who are excluded from dentistry services. I'm thinking particularly people with learning disabilities or mental health needs who again really struggle to either get access or anxiety about going to a dentist. So obviously you're starting with homeless people, which is fantastic. So that we're going to have the capacity to extend out so that we can have a dentist, a whole range of different people who can't access dentistry to achieve.
Because that's where our next plans are and looking at what we're going to do for next year. So this is one pilot that's built on something that started off in Leeds in West Yorkshire and has been sort of rolled out and the West families. What we also want to do is look at other vulnerable groups, other deprived areas, and actually work within the ICB at identifying those spots. So we are in the paper that's coming on later, we'll be able to talk a little bit more about that.
The thing I wanted to pick up was we talk about health inequality sometimes if it's a long-term issue, and then we've got the short-term issue of delivering things today. What I love about this is it's saying what we have to deliver today, we're going to do in a health equality way. We're going to target it at communities, which might be groups of wards or it might be groups of people. Actually, that is what we should be doing. It's not just health inequality isn't just about how we make a difference on some of those long-term issues. It's also how we provide services today in a more targeted way, which also means, and I've had this discussion with MPs recently, we might provide it in an unequal way. To give it to the people who need it most means some of the people who don't need it don't get it. We're all going to have to be open about that because that's what's going to make a difference on some of these issues. It's going to mean that. But I love the fact that this is a day-to-day service we're trying to provide in a way that's targeted on health inequalities, because I think that's what we talked about. And that should be a theme through a lot of what we do, but nothing else alone. It's a really good theme. So thank you, love. Kevin, did you want to come in?
Yeah,
okay. Lee.
Thanks very much. I'm Lee Althwaite. I'm the CFO, sort of miserable geezer, something to do with money. Nice to meet you.
That's you, by the way.
That was really great. I'm just really interested from a sort of public health perspective about how we get future at evaluating the social value associated with our NHS spend. You could target this service to lots of deprived areas, couldn't you, really, who aren't currently accessing dentistry. I'm interested, something with money, I'm interested in that broader social return on investment, but I know we're targeting homelessness specifically because versus MHL DNA because, and how do we start to think through which of these alienated deprived areas we target, because it will give us a bigger social value return. Because even though we've got hypothecated funding for dentistry, we're pretty brassic, notwithstanding that point. So how do we get really cute at targeting our interventions?
I think we've got to do a lot more work on that. That's a really good point. We talked there about the wider social implications, but actually we don't measure it, do we? And actually we ought to. We should be. It's possible to measure. I think. Emma.
Just on that, I think life expectancy for homeless people tends to be hard. So I think that, that to me is an absolute social So I think that's why we should target them. And again, it's about keeping people alive. And it's not just about treatment.
Life expectancy, work prospects, which has a huge impact on your whole general health anyway. We know that it's really important for people to be in work if they can be in work. That is going to be a stepping stone for someone, definitely. So obviously that's one of the impacts we could.
It's funny, I'd like to follow that through and measure it then. I agree with that, absolutely. I think work is a really good. If we got him into work, wouldn't that be bloody fantastic? Wouldn't that be a success? That's the kind of stuff. What we're good at is measuring the treatment bit. I don't think we're always good at following that through. But we know that's what we should be aiming. Leslie.
I think that's right. I think that was going to be my point really about some of the other ambitions we've got here across South Yorkshire. And I think those barriers that people experience, not just from homelessness and things, but from, as Darren explained to us, the broader outcomes of living that life for a while. And I think if we could look at the impacts on worklessness, because it's not just, it is about how you look, whether we like it or not, it is about how you look when you go for a job. But it's also about improving people's general health so they can work, isn't it? So I think both of those that we do need to measure that.
Thank you very much. And later when talking about our response to the dental plan, so this is should take some of these broader issues. Thank you. Okay, agenda item 6, Chair. I've only got a couple of things I want to pick up. One is we have established an EDI leadership group, which I chair. We had our second meeting 3 weeks ago, I think, Christine, and we will be coming back to this board for some of the work that we're starting to do. What we're trying to do is put a bit of leadership at a senior level around making sure our NHS organisations take EDI really seriously. We've got some really good ideas. This will come back to the board with our proposal. Not meant to be marking the homework of our NHS organisations, but it is meant to stimulate some action and give some ideas of stuff that we think is working. So I hope that group will come back, and we should probably report back after the next meeting here, Christine, if that's. I think that would be helpful.
Yes.
Sorry, someone say something? No. That's Christine. Sorry. Second thing I just wanted to say, I was going to say I was invited to a meeting of all chairs with the NHS board this week. Invite might be a rather loose term. And I attended anyway. And a couple of things. There's clearly a huge pressure building around the money. And that was before the budget today, and there were some worrying stuff yesterday of what the budget might include. I guess the big theme, and it's one we've talked about, and it's one we're talking about with our NHS trusts, and we'll come on to later. The big issue is productivity. A real stress from the centre that we're not really on top of productivity in all our providers, mental health as well as acute, although the measures are much better in acute than they are in mental health, which is worrying. And I think that will be a real emphasis in the next year or two. And I've got to tell you, I think that will be a real emphasis next year or two, regardless of which government is in power on the 1st of January next year, given the way the money's going. So big emphasis around that. It's something we've talked about and we're talking about to our chairs and chief executives. But I think it's a theme that this board will return to several times in the next year at least. That's all from me. Gavin, Chief Exec's report.
Thanks, Chair. So I guess I hope board members will receive my report and have to answer questions on it. But as usual, it's quite a long report, but I thought I'd just pick out one or two issues. And also just wanted to start with making the connection between obviously the work of the ICB and the Integrated Care Partnership, which is jointly convened by the local authorities and the ICB, with a particular focus on improving population health, tackling health inequalities. I think I was just struck by the patient story and that link to employment and the important relationship between employment and health. And I'm really pleased to say that this is one of the areas that the Integrated Care Partnership working together is absolutely focused on. And at our meeting in January, we came back to the employment and health relationship, focusing on some of the work that's already happening in the system, like the Working Win programme, which seeks to employ people with health conditions into roles in the NHS. There's the Pathways to Work Commission in Barnsley, which is looking at, how do you support whether that's people with long-term health conditions or caring responsibilities into paid employment. And at the meeting in January, we also looked at a programme around people with learning disability and autism, and how can we use the employment power of health and care within South Yorkshire to create good jobs for people with learning disability and autism. So I'm really pleased to see that connection. We have got the notes of the meeting back in November. I just wanted to mention smoking, which is one of our major challenges. And in November, we had a particular focus on tobacco control. And one of the things we committed to do was to add our voice as the Integrated Care Partnership to a consultation seeking to bring in legislation to restrict the sale of smoking-related products to young people, particularly under 14. Really pleased to say that consultation has been supported. There was wide support for that. So we're looking forward to seeing that legislation being brought forward. And of course, we'll continue to use the influence that we have through the partnership to hopefully see that legislation come to pass. So really important work in the Integrated Care Partnership space. I think operationally across South Yorkshire, I think the spectre of industrial action is still with us. So very recently, about a week or so ago, we had the latest period of industrial action, which spanned 5 days, which presented challenges. But I think it's fair to say that the health and the health system within South Yorkshire, I think, is I guess seems to be able to manage these events well, and clearly we've had a considerable opportunity to learn how to do that. I think more heartening news perhaps this week was the likely acceptance by consultants at any rate of a revised offer from the government. But we'll see. I think probably less positively, the doctors in training are balloting again their members for the mandate to take further industrial action. So we may see some further challenges down the line. But in terms of the most recent period of action, I'm pleased with the way that the South Yorkshire system has come together to respond to that. I guess just on that note, clearly our priority through periods of industrial action is to maintain emergency services. I think we've done that well. We are focused on trying to achieve as a system the national aim of 76% against the 4-hour standard. So that's people attending A&E get treated, admitted or discharged within 4 hours. As you'll see from the Integrated Performance Report, we struggled with that earlier this year. I'm pleased to say that over the last 10 days, performance has been in the sort of 70 to 75% sort of area. We're aiming to get to 76% by the end of the month. So there's a big focus on our emergency care performance at the moment. I think another area of focus is cancer. We've seen an impact on people waiting longer than 62 days to start their treatment. But obviously, it's quite a narrow time window. So taking a week out in terms of industrial action in some of our services does have an impact. Pleased to say that's an improving position, but we've still got work to do to get to where we need to be on cancer. I think perhaps more positive news on our efforts to address the longest waiting times for people waiting for planned procedures. So for a while now, we've maintained the position on 104-week waiters. I'm pleased to say that the number of people waiting more than 78 weeks now is less than 100, and we're on track to achieve the target of 0 by the year end, with one exception, which relates to corneal graft surgery, and that's because of a shortage of graft material, not because we're not ready to treat those patients. And we've also made good progress with the aim to reduce 65-week waiters by September this year. So I think positive to see. On the financial position, Lee will give us an update later. As we've discussed many times here, we started the year with a challenging plan, with a deficit of something like £293 million to close. At the mid-year point, we submitted a revised plan which was forecasting a deficit of 54.5 million. Pleased to say the position is stabilised. We're currently forecasting a deficit of 42.9 million, so slightly improved position, but clearly, a challenge going into the new year. And colleagues across the system are engaged in a planning process, and we'll touch on that later in terms of the new financial year. I guess we've talked about dentistry already, and we'll come back to dentistry. There's a lot happening in the primary care space. I think I welcome the publication of the National Dental Recovery Plan. I think, as Leah's mentioned, there isn't necessarily additional funding coming with that, but there is some freedoms and flexibilities and some new approaches, which I think we can build on. So I look forward to that conversation. The Pharmacy First service was launched since we last met. Again, I'm pleased to say that over 95% of pharmacies within South Yorkshire have signed up to that programme, and that aims to provide not only advice but actually treatment and medicines for common conditions to help take the pressure off primary care. So I think that's a particularly welcome development. I guess I don't mention in my report, but since I wrote the report, we've had further details of the national contract for GPs have been published. This was towards the end of last week. So there are some positives in there in the sense that it does seek to simplify the ways that general practices are paid for the work that they do, take out some of the bureaucracy and some of the I guess the uncertainty around income. But the planning assumption around increased pay to primary care is 2%. Now we know that in the context of inflation, which is considerably higher than that, that is a big challenge. So we're kind of waiting to see how that develops. There's something called the Doctors and Dentists Review Body, which looks at pay, and that review body will also have a look at this, and we ought to hear from them shortly. But I suppose it's just to recognise, the contract is out. It's not without concern for primary care colleagues, which I think is understandable. And I think it's just to make the point that a strong primary care, particularly general medical services, is absolutely integral to everything we're trying to achieve as an integrated care system. It's really just to acknowledge that difficulty, but also to recognise the important work that GP colleagues do. I guess just finally, just a little bit closer to home, I touched on the running cost allowance programme within the ICB. Board members will know that we were asked earlier last year to reduce our running costs by 30%, which is a significant reduction. We've been working through a change programme over the last few months. We're coming to the end of that from a people perspective. We have made some redundancies to a voluntary redundancy programme. There's still a relatively small number of colleagues who are at risk, and we're trying to match those colleagues with vacancies that exist within the ICB to minimise any further redundancies. But I think it just has to be acknowledged that's been an incredibly stressful and anxious time for our colleagues within the ICB, but I'm pleased we're coming to the end of that. We're also out to consultation with our staff around changes to our bases. So we've always been committed to having a base in each of the 4 places across South Yorkshire. We'll continue to do that. But if you look at offices like this one, it's more than we need, and it's also expensive. So if we can deliver our accommodation requirements in a different way, that helps to reduce our running costs and protect employment as well. So we're consulting with staff around some moves we're planning to make, which will see us co-locate with the local authority in Rotherham and Barnsley, and we'll see the colleagues who work in this building move to co-locate with the fire service in Air Street in Sheffield. Those changes will save a considerable amount of money, probably of the order of £1 million. So there's a considerable assistance to achieving that target set nationally. But I just wanted to update colleagues on that. The final thing, the final thing I wanted to mention was just to draw people's attention to the last point in my report, and it's just a fantastic campaign called Call My Name Right. It's being led by Dr. Rajiv Gupta, who's a paediatrician at Barnsley, but supported by Vivian Williams, who's our EDI network chair. And it's just a simple thing about showing that you value people by pronouncing their name correctly, and also not creating a climate where people feel as though they need to anglicize their names to make it easier. I mean, you know, a name is a kind of an integral part of who you are, and I think it's a really simple way that we can demonstrate value. So it's a bit of a plug, but if you can get behind that campaign, then please do. I'll leave it there, Pete.
Thanks very much. Any questions?
Some about policy first. I've had some comments from people actually that know me that have used it, and it's been received really positively. But I wonder how well we're publicising it as an alternative, and you know what plans we've got for that.
It's a good point. I think the honest answer, Leslie, is not terribly well, because it's had what I would describe as a soft launch. So I think to be frank, it was launched, but there's quite a bit of work to be done to get it to really. I mean, Anthony.
Yeah, happy to come in that. It was a softish launch based on the fact that whilst the pharmacists were ready to go in terms of the expertise that they provide, the system hadn't quite caught up with it yet in terms of being able to refer into that, etc. So a bit of a soft launch. The launch was very much a nationally based in the first instance. But Andy, we are putting some big work into some local comms of that. Leslie.
Well, as the arrangements get more robust, we'll reflect that.
It's a really positive thing.
I guess the other bit I'd be interested in, I think the board should be interested in, is can we measure the impact?
Yes.
This is about filtering people who can be seen in pharmacy away from other healthcare situations that don't need it. Actually, I'd like to know that it's made a difference, and what difference, what kind of groups of patients did it work in and which didn't it work in? Because I think we should just learn from it. Kevin and then Mark.
Thanks, Chair. Just a note about Mexborough Elective Orthopaedic Centre. It's really fantastic news, isn't it, that it's opened its doors, and I think reinforcing the place that Montague Hospital now has, even further in the community. But linking it back to your issue really about productivity, Piers, obviously this is serving predominantly patients from Barnes and Dodds and Rotherham. Yeah. No doubt Sheffield patients will get some benefit as well. But when you're designing these schemes from scratch, you automatically build in very productive systems, and are just reflecting as to whether this could be replicated almost virtually in our main hospitals, including Sheffield, and or whether there are lessons to be learned in terms of how those pathways work in hospitals, because this will probably be the most productive orthopaedic centre we have in the NHS in South Yorkshire. So what might the lessons be for other services?
So I think there are. I mean, I think Richard is obviously one of the partners around the Mexborough centre. I mean, interestingly, there is a sort of comparable facility being developed at the Hallamshire in Sheffield. And I think one of the benefits is the separation of planned activity from emergency activity, because clearly emergencies always take priority, and that sometimes knocks the planned activity off track. So having that separation is key. I think that idea of having a different model of delivery, I think is absolutely part of our thinking. So we've talked about things like the diagnostic centre, the Glassworks, and also at Mexborough again. If you can kind of, what really needs to go to a major emergency hospital. And actually, there's a lot that goes at the moment that doesn't need to go there. So actually, if you can find different ways of delivering that, decompress the major acute hospitals so that they're able to, because sometimes it's the pressure that drives inefficiency. Yeah. Whereas if you're running at 80% occupancy, whatever, oddly enough, it becomes more efficient. So I think it is part of the model. I mean, Richard, you're part of the authors of the Mexborough.
Yeah, I mean, I think you've probably captured most of it. It's the Sheffield electoral piece. I know we concentrate on revision joints, like other patients who waiting for that pain, those patients who refer to Sheffield. Slightly different in terms of policies. The Mexborough Centre was designed to deliver GERF standards, so we're getting it right first time programme in orthopaedics. and is a partnership approach between the three trusts. So 50% of the capacity is designated to Doncaster residents and 50% to Barnsley and Rotherham residents. And the aim is to get up to the equivalent of 8 joints a day, so 8 primary knee replacements, and that which would be the 64 joints a week, a 6-day week. We're clearly started slightly slow because the teams have got to get used to how we work in the centre and get used to the new team. That's from 3. We were supported by the National Reserve team, so as the Bruce's team came in and advised on layout, setup. And it is about standard operating procedures, really. It's about everything being in the same place in each theatre so that colleagues know where things are. And it's about being geared up to do that work as well and quickly as you can, but with a really great outcome. It's also based upon a 1-day length of stay. So historically in primary joint replacements, although length of stay is reduced, we're sitting at around about 3.5 days nationally. So if we can get down to 1 day, then obviously the capacity increases as a result of that. But absolutely what we're trying to do is learn the lessons from that in terms of how can you adopt services, model and standard operating procedures back in the acute hospitals, because as Gavin indicated, the orthopaedics, the challenges usually classed as less urgent, less emergency in its nature, and therefore if winter pressures into see, then those patients are often the ones that are disrupted. When you've got a designated centre, not on the acute side, the only reason that patient surgery wouldn't go ahead would be sickness absence, and obviously that is much less significant variable. So clearly we want to learn all the lessons we can to make sure that the old theatres are as possible and get to that 64 joints. If we do about 40% of the electric capacity that we require, and that then releases the other operating vehicle the subject to the same or similar ways in time.
Thank you. Thanks, Gavin. We now have a spot for questions from members of the public. Andy, do you want to talk us through that?
Yeah, absolutely. We've got a few. So the first question is from Peter Strelin, who's a Barnsley resident. He was primarily asking for who the contract were for FEND, learning disability, autism, and mental health. But he also noted that he struggled to find the exec leads for various elements on our website. So we've strengthened that. And he does have a particular interest in Down syndrome because of his own personal circumstances. So I think, Wendy, you know Peter, so you've offered to meet with him. So we'll send that offer to him very shortly. Secondly, we had a question from Julie Clark, who's a Rotherham resident. Julie talked about the Rotherham Council writing medication guidance and was asking whether NHS South Yorkshire had been involved in that, or whether it was just the council and the trust. And the answer is that the council have taken through some medication guidance through their governance process, to be produced by social care commissioners, pharmacists, home care and support providers. But they did include our Rotherham Place team, who did provide some feedback into that. So we'll go back to Julie and advise that we were involved in the creation of that medication guidance, which is for services that council commissions. And very finally, we had a question from Kerry Montgomery. Kerry wrote in about the NHS right to choose policy regarding mental health referrals, because she tried to make a referral to an organisation, and she struggled to do that because of the contract with Rotherham and NHS South Yorkshire. So we will be writing back to Kerry to explain the qualifying contract and how we can work with those providers to make sure that she can refer into those services, and we'll look to provide any further support that she needs. But we will explain how that works for providers that we don't necessarily work with on a regular basis.
Okay, thanks, Sandy. And you will respond directly to all three, and we'll post those full responses on the website. Thank you very much. Okay, thank you. Agenda item 9 are the place reports from each of our executive place directors. Wendy, can we start off with Barnsley, please?
Thank you, Chair. Just a few highlights from us. It's a bit of a longer report from us this time, but lots of positive things going on. You've got a summary there in terms of some headlines around our sort of performance. Just a couple of things to pick out from there. Is particularly around our A&E 4-hour performance. So I think we've credited the hospital. I think they've really tried to grip that challenge, and I think we've seen, certainly over the last 7 days, managing to achieve the 76%. Really been really great for the public, and certainly the staff feeling quite positive about continuing to improve on their position. A couple of other things to mention. Obviously, we talk about diagnostic rates in terms of our acute hospital. I just want to mention also diagnostic rates for people with dementia as well. And just the report that I got last night around our South Yorkshire position, that the South Yorkshire position is the best position across North Eastern Yorkshire on diagnostic performance for people with dementia at 74.6%, and nationally at 64.4%. So I think we should be really proud of that. But more work to do, I think, in that space in terms of antipsychotic medication for those individuals. So we're going to focus on that. We had a really great conversation with our counsellors about primary care. We felt it was really helpful to bring a conversation together to help them to understand what primary care is about in all its glory, and also to tackle some of the myths I think that sometimes exist around primary care. We found that a really positive conversation, and engaging more counsellors in the engagement forum around primary care, I think, are really helpful. We've had some pressures around intermediate care as well. Our intermediate care service in Barnsley has been delivered through a residential care home with the care provided by our hospital colleagues. But we've been able to find a short-term solution for that, which we're really pleased about, that will see us carry through over the next sort of 18 months while we work on a more sustainable solution for that, which will need, of course, some creative thinking about capital around that. You've got some headlines in there about some of the great work that's taking place in our children's services as well across the council. It's very much a partnership effort with the launch of our Children's Social Work Academy, and really trying to drive into that that challenge around recruitment and how to encourage people to step into both health and social care careers, and we'll be doing more of that work, and we think we're successful in a funding application to help us to support us to develop that work. The other thing to point out, we've got some great success as well, really, in terms of the Active in Barnsley strategy. One of the big ideas in terms of 2030 is helping to transform communities through moving more. And again, we want to try and get organised, because we understand there will be some further resources coming forward to support us to do that in terms of our adventures to tackle things like obesity. And probably just a couple of other things to highlight really is that we continue on with our, I keep calling them adventures, I think they are adventures. We continue on with our adventures in Barnsley around our health on the high street. As Gavin's mentioned, we've got some really great success around the community diagnostic centre. And we continue to imagine what our next chapter might look like in that space. So a little bit of a, I'm not going to say anything about it, but look out for a big press release tomorrow about what our next chapter is going to look like for Barnsley. And I'll leave it there.
Thank you, Wendy. You wait with basic questions. Any questions, Wendy, other than what she's talking about, which you're not allowed to question?
Sorry, Wendy, there's a theme in the things I'm going to ask you, but the evaluation of the family hubs in North East and North Barnsley, and that sort of broader provision motif and their downstream impact on demand for healthcare, have we started to conceive of how we're going to do that evaluation? Because I think that's where the special source is probably for us, if we can do that well.
I don't believe quite yet, because literally it's been quite a job to almost like move from what's previously been a children's centre type of offer to a family hub orientated approach, really. And that's been quite tricky for us around not just the estates, but navigating that conversation, of course, with our neighbourhood. So I think we're just getting going in that sort of space, but clearly understanding and learning from that will be really, really important as we think about how we mobilise ourselves into a research approach and across our partnerships. Is it quite right? Yeah.
Is it perhaps worth thinking through how we link the sort of fledgling evaluation in the sort of Sheffield model neighbourhood to that approach? Because if we can come up with a sort of common oversight methodology, it might help us. I know the solutions might look different,
Yeah, possibly. I mean, I think there'll be something about collaboration, I think, with Children and People's Alliance in this space, I would imagine, ever. I think in terms of, working with the GCS, the Directors of Children's Services, working through the Alliance, possibly about understanding and realising what that's telling us. And it's similarly, I haven't mentioned it, but it was an action of earlier on, about the virtual ward evaluation, really. I think the similar thing around that, which I'll pick up a conversation with David about how do we get a real rich picture about what what against the virtual ward model, and what does that mean in terms of quality? What's it mean in terms of managing, flow and demand? So we will bring that forward. I think it's a joint South Yorkshire meeting due course.
Thank you. Thank you, Lee. Any other questions? Doncaster, Anthony.
Yeah, thank you. So a few things to concentrate on this month. The first is that we're very much in the thick of putting together the place plans for next year. As members would expect, this is a combination of the strategic view of what is our health and care vision for the city over the course of the next 3 to 5 years, but also obviously the immediate pressure of our demand mitigation and efficiency schemes for next year. We're using the 3 horizon view on this, and we've landed upon the 3 priority areas of right sizing complex care within our hospitals, integration of an alignment of primary care and community health, and developing our community prevention approach. So obviously we're really working behind the detail of that. But if I could point to the right sizing of our hospital, and we may look at the terminology of that, I'm certainly interested with bated breath of the work in Barnsley. I think there is a lot we can learn, frankly, across all our places. But we do have a good commitment across our partnership around the most appropriate and best use of public and private estate across the city. And members will know that to a large extent, this is motivated by the poor estate of our main acute site. So in the next year, we'll be doing a lot of work on decanting of appropriate services away from the DRI side, and right to the forefront of those plans are services such as audiology, pain management, pre-assessment, etc. So more to plan in that space. But as already been mentioned, there's already some exciting use of estate and capital and technology in Doncaster. I won't go back into the elective orthopaedic sector, but thanks for mentioning that, Kevin. I think that really is at the forefront of the work that we want to do. And as we said, we've already seen some positive results in terms of productivity. The report also highlights the exciting development of technology such as surgical arm at the DRI site and the work in colorectal there. And there's a great picture of Richard posing behind that in the report. To the areas of demand mitigation, members will see description of successful peer support schemes that we've got running across Doncaster with our charitable groups. As an example, a patient focus group there in the ED department. We're also looking at peer coordinators to help our hospital at home programmes. We are making greater progress in our virtual ward approach now. I really do feel that this is embedded within our clinical teams. And we have a celebration event actually being run at Ardash this month, which I'll communicate across members. Seeing good progress in that area. Equally, members will previously hear me talk about the success of our citizens advice scheme, advice on prescription, that we've now got rolled out across all our primary care settings that give valuable social advice to our residents. And we know that this is having an impact upon the lives and diversion away from services. Preempting the question, we've got to be better at measuring it and evaluating it. And we have started to get some data and some intelligence behind that. But it'd be good to have that conversation, Lee, about how that's landing. Our Place partnership is very much involved in the wider Team Doncaster partnership, which is charged with implementation of our city strategy. Some of the report highlights some of the good work going on in terms of health care employability, and we've employed a role in that, which is having some good early success. And also we've highlighted the works of our DART scheme in terms of charitable schemes on really bringing active well-being to some of our residents. The last thing I wanted to mention that isn't in the report is that we're hosting in Comisborough a group practice wellbeing day on the 23rd of March that brings a whole host of organisations together, including Macmillan, Citizen Advice, South Yorkshire Fire and Rescue, Diabetes, Age UK, just to name a few. And the objective is to rekindle a sense of community spirit within Conisbrough that brings these services together to do the whole offer that we've got for our residents. So I'm really excited about that event, and I'll feedback accordingly.
Thank you, Anthony. Questions for Anthony? Thank you. Rotherham, Chris.
Yeah, no problem, Chair. Thank you. So just a quick update from me. So children and young people. So we could just talk about the response to the safeguarding review, but so just to celebrate as well, our Looked After Children 4 have been nominated for national awards. Looked After Children has been an issue in Rotherham since the child sex exploitation issues in 2016 and beyond. And we've had very high levels of Looked After Children, and obviously support to Looked After Children is extremely important to us. That's great news. In terms of our place board, we look at performance on a monthly basis, and that's not just NHS performance, we look at the whole place performance. And the two things I'd just highlight from that is, rather than we are challenged in terms of the 4-hour wait standard in A&E, that's something that's a key priority for us to work as a partnership to resolve and to try to meet the 76% target. But on the better news on performance, we ranked first in England across 106 trusts for diagnostic waiting times in the setting. So there's challenges and good news in the performance. In terms of estates, 2 big developments in Rotherham in 2024 in estates. We have a Green Lane Primary Care Centre, which is doubling in size of a primary care centre to take account of all the additional roles in primary care. That, I'm informed, the keys will be given to us on Friday. So that will exist and will open, and we can, obviously, Andy, I can work with Andy to get some communications on that. And then our other one, which is at Waverley, which is the new housing development next to the Advanced Manufacturing Park. That's a brand new health centre for the new population, new housing development, and that's scheduled to open the 24th of December this year as well. So that's well underway. In terms of place board, last month, learning disability and autism was the key priority, and received and signed off the plan for people with learning disabilities and all age autism. So that, again, it's a well-known issue for us in terms of long wait times and getting services that fit the purpose. We've been working with family groups, patient groups, and we've got a plan that hopefully everyone's signed up to and we now start to deliver. We also picked out some case studies, so this is some good work. I have to say this because she speaks next to me, but good work from Voluntary Action Rotherham, our voluntary sector, and our primary care networks. There's a couple of case studies, I won't go into them, but I just try to show the value of looking at the whole person, not medicalising someone, not turning them into a waiting list. It's about how do we look at the preventative end of the agenda and not just looking at health, looking at the whole person. And then finally, on health inequalities. When you work at a place level, when we talk about health inequalities, we don't necessarily think about Rotherham as a whole. We tend to think about our localities or boroughs or wards. And we do some work targeted in 2 of our more deprived areas in Malby and Livingston. We're trying to learn the lessons to then move out over Rotherham. So the paper just pulls out a few examples of the case studies we're trying to pull through in terms of trying to really get under the skin of health inequalities in Rotherham. So there were some highlights, Chair. There's more information in the report if people want to refer to it.
Chris, thank you. Leslie.
Thanks, Chris. I was really interested in the engagement work around long-term conditions, because I think we've known for a long time that the impact that has on people's whole life in terms of their income levels and in terms of their ability to kind of live, you know, a positive and happy life. And I just wonder whether there's an opportunity for us to hear a bit more about at a future meeting. Might be a good patient story. Something very different there coming through. I'd really like to know more about it as well. So thank you.
We can work together on that. Can't we pick that through?
Thanks, Leslie. Any other points? Thank you. Sheffield. Emma, please.
I make no apologies. The focus is on the Sheffield Palm. I talk about the Sheffield Palm because this is just an NHS issue for us. This is about how we work with our partners, particularly our local authority in this space, to ensure that we absolutely start to change the way we deliver health and care in the city. I think I must have been sat next to you, Lee, for too long. Which we talked about. So in terms of what
you have our sympathy.
I'll just maybe any questions you might ask me. But I'm not miserable. So we had a really good session in this room actually at the beginning of February, where we brought in all the chief execs from providers, from local authority, the voluntary sector, just to talk about where we are really in terms of, how we've progressed in the first year. Were the priorities that we picked the right ones? I'm glad to say that people did think they were, so that's helpful. We've added a couple more into our programme, particularly around medical management and optimisation across the city. And also estate, we have a lot of estate that is not being used properly efficiently, and we feel we can make some cashable savings pretty quickly if you start to look at that. I think we've also looked at things like demand management. And again, having worked in the system for years, I think demand management is really hard to do without taking into account the ageing society that we live in, the pressures that we're going to see, particularly on areas such as diabetes, chronic pain in the future, chronic kidney cancer, chronic kidney disease. Areas such as that in 2040 will really have increased a lot. So we're trying to think about what we do now, but also how do we plan for those changes in demographics, and how do we start to target our population differently? It's what you were talking about earlier, Chair. So we're doing some sort of short-term work, looking at the longer-term picture and thinking about, what is the structural change that needs to happen? We can't tinker around the edges with this, but actually in Sheffield, where we've got, 1.3 billion pounds worth of spend, are we using that spend in the way that we should be? Are we looking at our standing operating procedures, which, as you say, are we applying all the kind of guidance around the National Audit Office guidance that comes out to make sure we're sweating that pound, we're sweating that asset? And what do we need to do differently? Because I think we need to be thinking about that structural reform rather than just, if we did a bit of demand management around ENT, what would that deliver? And how do we take our communities and our local politicians with us in that space? So that's really where our focus is in Sheffield. And obviously, how do we start to work differently in our new target operating model within the ICB and take our partners with us? So the detail is there. I'm not going to sort of go through it verbatim, but it's just kind of an overall picture of what we're at. So we're absolutely focused on the money.
Thank you. Any questions for Emma? Thank you.
Yes, let mine.
Oh, sorry, David, I didn't see your hand up.
Just a brief one. I mean, the term reducing demand can be seen quite negative, but what we're trying to do is really people to have the right care at the right place at the right time. So it's just to frame it in that context of what we're trying to do with all the work that's going on.
Yeah, I think we've all been to A&Es where you're sitting there thinking, and I was at one in, some as you know, in London before Christmas. You're sitting there looking at all the people in A&E and you think, you might need something, but you do not need to be here. I think that's true of virtually every A&E. We walk around it tomorrow, and those A&Es are overwhelmed. So you worry that the really, really ill patients don't get the service they want, and yet the people there need something, and it's getting that right and intervening in that so they know they can get something. That's been a problem for years. And what's interesting is we have lots of schemes that make bits of difference. We've really got to take a larger scale view of this. Sorry, Moira.
Yeah, I mean, just it's really positive to see, that whole system discussion about the Sheffield Pound. And I know, we've talked about place pounds for a long time, haven't we? And it's actually making it a bit of a reality because the money is using. But we know there are better ways of delivering better care, but it does involve people pooling their resources really and then reallocating it. And I know that's a real challenge. So credit to Emma and to a team to got people in that place at this stage, and I know other colleagues will be doing the same.
Okay, thank you. Can we move on then to items for consideration and discussion? We start off with planning, which covers both the forward plan and financial plan, and then we move on to dentistry. Will you even introduce me?
Yeah, can I kick this off and
please?
No, Marianne has joined to give the fuller update. So just to position this then, so this is a paper which is setting out a requirement of us, an integrated care board, to update our joint forward plan. And many of you will be thinking that it wasn't that long ago since we actually did all the work to engage and develop the joint forward plan, and it's not really, because actually September was the time that we really launched that. So you'll see reference to light touch in this, but as you can see, there is some real consideration in terms of a wholehearted update where that's appropriate. Just a couple of things that I want to highlight, and then Marianne will just go through some of the detail. There is a set of guidance that's published in March, so I'm just mindful of the time period within which we're doing this is actually relatively short. But I don't want the board to think that we haven't done due diligence in terms of engaging in all the right places and spaces and with our partners, and where that's appropriate, our communities in that. And Marianne will take you through some of the detail of how we've been able to do that. And you'll see on page 7 there are some, there's some significant areas that we've pulled out, and we'll highlight a few that are important to note. But also in the areas that we're updating, part of that is from some of what you're hearing today, which is the progress that we're making, and the progress we're making on, on the plan and in really important areas. So we'll talk briefly about pharmacy first. Gavin mentioned the work that we're doing on smoking. Some of those things are in there. There is some new stuff that came out just after we're on the brink of us publishing our joint forward plan as well. So we'll pick up on elements of that. When Marianne's updates, I think just come back to a bit about what happens next, because we'll go through the next steps, because I'm mindful we're here at the beginning of March, and there's still some engagement work to do and time for feedback. So we'll just come back to that discussion so that folks feel assured around the process that we'll go through over the next few weeks. And if you don't mind, I'll ask Marianne just to give her a
welcome. Nice to see you.
Morning, everybody. So those of you who don't know me, I'm Marianne Hargreaves. I work in our strategy and partnerships team here at the Integrated Care Board. I've just got a couple of slides just to illustrate some of the key things in the paper that I shared ahead, if that's okay. And the first one really is just a quick reminder, just to refresh ourselves of the ask around joint forward plans. So it is an ask of us as an Integrated Care Board with our NHS partners to develop a strategic plan. The expectation is that we refresh that plan annually. That what it does is it sets out our approach with respect to how we will arrange and provide services for people from a mental health and a physical health perspective, that it aligns with our health and wellbeing strategies, our place integrated health delivery plans, that it responds to our integrated care strategy and starts to act as a shared delivery plan in relation to that, and that it helps us to articulate how we plan to meet the requirements that were set out in the NHS long-term plan, so the universal commitments, and of course the kind of list of legislative requirements that you'll see that's set out in the guidance. So we published our initial joint forward plan. You remember it came here to the board in September last year, and then we received refresh guidance from NHS England at the end of December. The guidance was still quite permissive in terms of local ICBs and systems enabled to set the scope and expectations in their plan. And so the approach that we have taken is very much, given the fact that it was a plan that we published at the end of September, light touch. So we worked virtually through our joint forward plan coordination group. That's included all of our place partners. It's also included our collaboratives and our alliances. We've reviewed the guidance. We've refreshed our joint strategic needs assessment. So that's an understanding of our population health needs. And the plan is that we publish that alongside our refreshed joint forward plan at the end of March. We've reviewed our engagement approach. So you remember last year we set off an approach with our What Matters to You campaign, and that informed our integrated care strategy. And then we did some further work with our health watchers to reach out to some of those communities that we don't ordinarily hear from as much. What we've done with respect to our refresh is we've aligned our engagement approach with the work that's been taking place to inform our Start With People strategy, which is our involvement strategy as an ICB. And actually we've connected again with our health watchers to reach back out to those communities to share an update on how their feedback informed our plan, but also to kind of have that conversation about how that's working and how we can improve that involvement work, and then more specifically some of the areas we identified to strengthen. So we work with all of those stakeholders to identify some of the areas where we could update and strengthen our plan. We're trying to use it as a bit of an opportunity really to bring it refreshed. We've aligned those conversations with the dialogue that's been happening around confirming our priorities in each of our place partnerships, our provider collaboratives and our alliances. And what you have, a link in the paper today, is a link through to the engagement draft. At the moment, I have shared that with a similar cut paper with all the kind of key changes indicated with each of our place partnerships, with our health and wellbeing board. So from a place partnership perspective, I've shared that with the deputy place directors with respect to enabling place discussions. From the Health and Wellbeing Board's perspective, I've shared that with our DPHs and those that support health and wellbeing boards. So that's a mixture of local authority colleagues and some of the local authority connection roles that we're developing to support the ICP. I've shared it virtually with our joint health overview and scrutiny committee. It's also been shared with our health teachers. So we've tried to share virtually as much as possible to enable people the opportunity to have a look at the refresh. I think the key thing to say is there aren't any major changes. What the process has really done is reaffirm the priorities that we identified in the plan initially when we published it in September. What we have done is refreshed some of the other elements. So my next slide just gives, I won't take through all of these detail in the paper, but it just draws your attention to some of the key bits that we've updated. So we've updated the needs assessment. There are some new areas in there, particularly things like women's health, men's health, end of life care. You'll notice that we've included some more detail about our developing plans to address women's health, our plans to improve the care that we give with respect to palliative and end of life care. We have also strengthened some of the case studies. You'll see there's reference there to the increasing collaborative effort with respect to tobacco control, and that was supported by our integrated care partnership this year. There are a number of areas where we have made real significant progress. So with some of the elective developments opened their doors towards the back end of last year. So we've updated those case studies. In terms of continuous quality improvement and research and development, we've of course made progress with the strategy and action plan there. So we've refreshed that section. From a digital perspective, we've updated some of the priorities in there so that we've ensured that there's an increased focus with respect to supporting primary care access. And we've reflected some of the kind of developing language around anticipatory care from a supporting people in the community from a perspective. There is more detail in your papers around some of those changes. So my last slide really is in terms of next steps. And you know, the work at the moment that's very live is ensuring alignment between our joint forward plan and our operational plan and our financial plan. In terms of next steps, it's the opportunity for me and the coordination group to see the feedback that we receive from yourself as the ICB board, from our place partnerships, health and wellbeing boards, joint health open scrutiny partners, and then onward we have a slot at the System Leaders Executive Group in mid-March. And then we also have a slot at the South Yorkshire Integrated Care Partnership towards the end of March, with the view that we take on board the feedback, finalise our plan for 24-25, and then we share that online in line with the guidance for next year. Apologies, I started to get crazy. People didn't cough then, maybe through that one.
Mariana, thank you as ever. Any questions for Mariana? This is really describing work in progress. Mark?
It's only a really minor point, and it's for context, but in the last week of the week before, the department actually wrote a letter to the Public Accounts Committee with an updated definition of anti-hosting. It just might be worth having a look at that.
Thank you, Mark. That's helpful. Hey.
It's really helpful to see all the changes, Mariana. And I was just looking at the bit that talks about an update to the section that articulates how we work with partners to address the needs of victims of abuse around the serious violence duty. So it's really great to see that in there, because I know we had feedback particularly from people working in that field who felt that maybe that could be strengthened within the plan. So it's really good to see it there. I was just wondering particularly whether you'd already been talking with sort of key players around that, in terms, I'm particularly thinking about voluntary sector organisations who might be working within this field. What's being done to connect in with those organisations to think about that strategic approach?
So in terms of supporting victims, so I've been working with our quality colleagues from that perspective, and that's where we have made some updates to that section, reflecting the, I suppose, the continued evolving governance in that space and our role as an ICB in terms of contributing to that duty. So I've been working with quality colleagues at the moment to update that section. With respect to VCSE, we have shared the refreshed version through the VCSE Alliance. So if you think that onward there are some local VCSE organisations that we should further connect with from that perspective, then we can do that onwards.
If you could let us know, Lucia, that'd be great.
Yeah.
Thank you. Kevin?
Chair, and thank you, Mary. Very, very clear. And it's almost really reassuring, isn't it, that there's no major changes to that. We're most concerned if we were starting afresh. So that's good to hear. I'm conscious that our original 5-year forward plan was only published a few months ago. So it's really about scheduling forward, about when we as a board start to reflect upon how we're making the progress. Because we often get accused, don't we, of focusing on the plans and revising the plans, but it would be good to hear at a time in the near future that we're actually doing the right things, the things that we said we would do. So I just wanted to share what time we've got for that.
The answer, I think that's really important, but I don't know, we need to talk about it, but it strikes me that in the autumn, we should take stock to say, we said this, how much did we do? My words, better way of framing it. And in a sense, a theme of the miserable old bugger next to you legitimately is, are we measuring this?
How is it going? Not precise.
But it is about how we measure this, and that we've got to move from some aspirational stuff to some measurement stuff. Because if we don't measure this, we'll end up only doing the stuff that we can measure, and we know that. So we've really got to do more of that.
This is our raison d'etre.
It is absolutely right. And you're right to raise it.
We've got to tell the public how we're doing.
How we're doing. Well, let's make sure we pick that up. I'm saying the autumn and one of our informants start.
Can I just come back in on that?
Please, Will.
I'm glad you've asked the question. I think that's really important, and it's just to give a bit of assurance, really, that we have started that work. So as part of the refreshing of the joint forward plan, Mariana and colleagues have done a bit of a stock take. You'll note that actually it started to inform the shape of how we would go about doing some of our planning this year for our operational planning. So Lee will probably pick up on it, but I think we should do that, and I think we probably should do that sooner rather than later, so that we can actually see where we are making progress and where we might need to put more emphasis.
David.
I was going to pick a bit from this report, but in previous boards, I brought a population health prevention type update. The team have been working that we could maybe bring to the next public board smoking and cardiovascular prevention, because they have been priorities. So bringing everything all at once seems to be too big, but there's an offer that might
be really helpful.
Agenda.
That'd be really helpful.
So I was just going to make a point about if you look at our IPR as well, some of those high level population health outcome measures we've incorporated in the IPR. So as part of our regular business, we'll always be looking at those kind of high level impacts. I think you're speaking to them, but I think you're also thinking about the specifics we said we would do within the plan.
Yeah.
So clearly we'll come back and update on that, but we can look at the high level outcomes impacts as part of our IPR.
Okay, thank you. Marianne, thank you very much indeed. Lee, we're going to talk about money for next year.
Yeah, I think you only need to hear from me once today, but there's quite a lot of content in the finance update. I'm going to talk a little bit about month 10, a bit about the financial forecast and that deficit and its consequence, and where we're at with financial planning. So if we want to punctuate any of that with questions, just stick your hand up before we get to the end. So the month 10 position, as it says in the paper here, where we've got to is an ICB, is we're broadly breaking even. So as a statutory organisation, we're broadly breaking even at month 10. But the position at month 10 with our hosted providers is we've got a £43 million deficit, and we're as concerned about the deficit that sits in provision as we are about the overall ICB position. So when we're reporting to NHS England, we're talking about both of those numbers, but we're broadly breaking even, meeting our statutory duty month 10 as an ICB. But overall, we've got quite a big financial gap that's currently hosted in the provision space. So that's just to note the month 10 position. What we're now saying about the forecast position for the whole system is we are likely to get to a deficit position of 48.6 million as a whole system. That is not a good news story. For the avoidance of doubt, there was a consequence of that. The consequence of that is we need to start to pay that money back, and it will be removed from our allocation in 25-26. It's a 2-year lag. So if you say, well, what's the consequence of not hitting your sort of financial numbers then? That there's a sort of, that funding is then circularised within the NHS. So we have to start paying that deficit down 2 years out. So that's the consequence. So the good news story is NHS England have kind of accepted that, and they've got national coverage for that number. within the overall sort of vote of the English NHS. But the bad news is there's an expectation that we start to pay that money down. So that's the consequence. So good news and bad news. All of our focus though now is what a sort of landing year end is on the sort of financial planning for next year. And I was going to go through that in a slightly sort of stepwise way and just Mariana is doing, she's nice in the room. Mariana is doing enormously diligent work trying to keep us in step, workforce, operational planning, activity planning and financial planning. But as you can imagine, there's lots of moving parts in that to try and keep us in step and sort of late breaking news in that. We're trying to keep this triangulated planning process going with workforce, activity, performance and finance. But that's quite hard. That's just to note. It's a bit difficult. But where we're at with the sort of planning process is I think we've got really good engagement now, trying to do planning in a different way, keeping in lockstep the ICB and our 7 hosted statutory NHS organisations. I'm not saying it's a panacea, but we've got a mechanism through both system leadership executive on the executive side of the street and through a chairs and chief execs forum about trying to make sure we've got shared and joint ownership of the plan in the NHS in South Yorkshire, which I think is positive. I don't think we were lamentably bad at this before, but I think we've solidified that this year. What we've agreed to do is set the starting position of the plan on the run rate cost of the system. So that's the current carrying cost of the system. Previously, how we've tended to do this is go back to something called the underlying position, which is kind of a bit of a caricature, but has got everything in it that we may or may not be able to find or employ and other things. So it's now easier for us to tell the story to NHS England about the starting deficit position for the system looks like this based on the underlying position of the system, which I think we can articulate rather well. The next conversation we've had with all of our hosted providers is there is some growth coming into the system as we move from 23-24 to 24-25, but we want to be a little bit intentional about how we use that growth. We want to have that conversation in each place partnership and say, we could either use that to pay some element of the deficit down, or we could invest it in specific things that might help with demand prevention, or there might be things that we need to kind of hold back as a cost contingency. But we're trying to have that conversation in each of the place partnerships, and I'll furnish a bit more detail around how we dissect the plan into place over the next week to some of the colleagues around the table. So there's that work going on. And the main thing we're working on now is this kind of, that there's an appendix in there which sort of describes sort of 6 steps to how we sort of identify efficiency and a way in which we can abate the overall sort of financial challenge in the system. The 6 steps sort of start with a relatively conventional, can we find a mechanism to reduce costs in provision and the directly controlled spend of the ICB? We're doing that work now. How then we can come up with a plan at each place around how we're going to affray demand, as we've just been talking about local initiatives, about community development. Doing some of the modelling for that work is quite hard. Candidly, if it was easy, we'd have done it all already. So we're very much hunkering into how can the place partnerships seek to address reducing demand into secondary care, both mental health and physical illness. But then do some work with the collaboratives to look at, have we got plans that straddle across the acute federation and our MHL DLA collaboration? And we do some work with Kira just looking at, have we got a clearer understanding of sort of population health elements of this, about who's consuming resource for particular segments of the population? Where we're trying to avoid, candidly, is not getting into that sort of difficult choice work about service cessation and stopping it. But obviously that's all reliant to live within our means of doing these 4 first steps really well. The numbers that we've reported in our first cut of the plan earlier this month, I can't remember which day it was, things go spinning by, is we've got to a position in the system of a sort of a predicted deficit for next year, 134 million. So that's based on run rate cost. That's based on an understanding of non-recurrent issues that we don't think we can do again. It's then based on a starting position on efficiency of 3% across the whole system. That is not the end point of this. What we're now trying to do is dock into that position each of those first 4 planning steps about how we can improve that position from 134 million. We'll take this back to SLE in a fortnight on the executive side of the street, and shortly after that, we've got another chairs and chief execs meeting. So there are another 2 opportunities to resubmit the plan. The next one, the 21st of March, and the one after that will be the 2nd of May. We will just see how we go in terms of trying to abate that starting position about the financial imbalance. The tricky bit is obviously keeping that all in step around operational imperatives and other issues. I will stop there, Chair, but I recognise there's quite a lot of content here. Again, it's a bit of a work in progress update, but Gavin and I and colleagues are bearing witness to a number of sessions with NHS England colleagues today, tomorrow and next Wednesday to go, where are you at in the planning process and how do you think you can address some of the gaps in the plan, not just financial, but more broadly? So there'll be more to follow this, sir.
Thank you. Any questions? Kathy?
Yeah, I suppose it's just kind of following up the conversation that we had yesterday at execs in relation to, and I kind of recognise this is the financial improvement approach to this plan, but actually when we're talking about transformation and disposition of services, difficult choices to bridge residual financial gaps, and also workforce reduction, where in that process we'll build in equality and quality impact assessment processes. So doesn't mean we won't do those things, but actually we clearly understand the risks or benefits of taking forward those proposals.
Yeah, I agree. I think pulling this together as the proposals emerge is going to be the challenging thing for us, Kathy. Wendy?
Yeah, totally helpful. I think there's an additional point, which is the partnership point in many ways in this, and the exploration I think that we're having collegially with local government colleagues in terms of the burning platform that they're presiding over, also particularly with regards to spiralling costs of placements for children and young people with additional very complex needs that often need one-to-one wraparound support, whether that be in their own environment or in other environments, really. And I think what we're seeing is a need for us to corral some targeted action in that space, really, and it's really encouraging that those conversations have started. But there's a real relational piece there, isn't there, about what we can do as a shared leadership team in that space, but there's also the interface with the mental health and disability and autism collaboratively in Children and Young People's Alliance. So how do we lean into that to understand the problem in the first instance and to figure out where can we add value together, I think, to make a difference? Because it's a very independent sector-driven market again, very much as we often see in things like eating disorders, etc., and other spaces. So it's just something we need to group, I think, together.
Yeah, I think Gavin and I saw all the leaders and chief execs 2-3 weeks ago. And I knew this, but what is interesting, the difference this year than, say, 3 years ago. 3 years ago, the local authority leadership would have been talking about the difficulty around social care. Every local authority leadership, and I know it for personal reasons in Derbyshire as well, the real financial pressure these days is around children's services. That's true of every local authority. The scale might be different, but the cost of provision of children in care in its broadest sense is gone through the roof, and they are really, really struggling to cope. And clearly it's work, we've got interest in, we've got to work with them around that. You're absolutely right. Clearly this is working. Sorry, Kevin, please.
Sorry, late.
Always welcome.
So thank you for this. It's clearly a really challenging process, this, not only locally but nationally. So just reiterate previous comments I've raised around, just refer to them, not to talk about, around the service implications of using the run rate approach, which I do support. I think that plays to the needs of the triangulation, Kathy's points around workforce quality, and then we're absolutely excited about what we might be forgoing as a consequence of that. So just refer to previous conversations. We've previously approved or supported the financial improvement approach, the 6-point plan. Inevitably, we're going to be stuck in the loop for this year, focusing on points 1 and 2, the ones that are in bold in the presentation. We do somehow need to break out of that cycle and get into where the good stuff is around transformation and service. And I just wonder how we might use any development resources we do have to have an eye to the medium term where we've got to start unlocking that, because numbers 1 and 2 will run out very, very soon. So we've got to build in the capacity, I think, in places, in providers, to look at the bigger picture going forward, whilst our existing capacity is doing the day job. So just urging us to try and build that capacity in place.
And you're right, Kevin, we are very clear that the transformation work, be it in the collaboratives or a place, it's going to be really difficult to they could deliver big money this year, big change. But if we don't start this year, they will deliver it next year.
Right.
And actually, we need to try and hasten that, I suppose. Lee?
Just to respond to those 2 points, I think Kevin's very sensibly challenged me on that before. It's a really sensible challenge. I think what we've got to do is we've got to think through between the 21st of March and the 2nd of May, how do we build in enough time to do something really intentional about the consequential impact of pushing the plan this hard financially means this in terms of quality and performance, and think through that, the quality and quality impact assessment process, and just think that through. So I think we just probably need to take that away and have a bit of a think initially on the executive side of the street. And I think Kevin's absolutely right. I think the gestation of some of that broader thinking in sort of 3 to 6, we've got to give ourselves the latitude to think through what does that mean on a sort of multi-year time horizon, which doesn't invalidate that being divine thinking. There's stuff in 1 and 2 that'll have a nearer term impact, but we've got to find some energy for doing the things in 3 to 6, because not necessarily 6, but certainly 3 to 5 in terms of just thinking through differently. How do we work around here? So I think there's something about both the multi-year financial model that we can start to generate and thinking through, just because it doesn't impact on year 1, it doesn't mean it's the wrong stuff. So I'll go in, well, we're going to think about that as well. So that conversation's been helpful, Sharon. Thank you.
Thanks, Lee. So we have a return to go in at the end of, oh, sorry, Richard, I apologise.
Yeah, thanks, Liz. I would just echo that. So my experience at times like this is the time to start to do the right things right and stop the wrong things. Try and make sure that the messages we give to colleagues are about keeping the system in balance. We need our services to be safe and sustainable. We need them to be effective and efficient, and we need them to be able to live within the resources we have. And when things are tight on resources, we have to sort of make sure we don't mix messages up about what we're trying to achieve overall. I'd echo Kevin's point that at times where nationally we've mixed up those messages, we've usually had significant challenges. So to me, it is do the right things right and stop doing the wrong things, and make sure you do it within the resources you have, because if we're not financially sustainable, it becomes incredibly difficult to do the other things that are actually our messages. Let's do the 3 things right and get it working as well as we can. And we've heard examples in here of CDC, NEO. They're about doing the right things right with the right outcomes for our patients. So let's figure out which one of them we can actually drive really hard on. And if we do that, I suspect we'll move forward and be better tomorrow than we are today.
And that's right. So let's just go through. We will be putting a return in the end of March after going through another meeting with chairmen. I think we've got an informal in early April. I think a lot of that will be around what the year looks like, including this financial plan, because there will be a further return. Is it the beginning of May or the end of April? 2nd of May. So we'll have, let's assume that our informal board meeting in early April is predominantly around planning this year and the planning. Okay, Lee, thank you. Dentistry plans as part of what are our plans? This is an important part because there's been some new guidance out.
Yeah, thanks, Chair, and thanks to colleagues who are going to help me with this this paper, because they've offered it and are also able to answer some of the more technical aspects about it. So members will remember we came to the board to present on the Primary Care Access Recovery Plan, which covered all areas of primary care, and the board asked for a further deeper dive into the dental position and our plans for that. As you say, Chair, this is timely because we have been planning our local dental schemes, and last month NHS England published Faster, Simpler, Fairer, which is the national plan for recovery of dental access and some of the longer term workforce sustainability plans. That is referred to throughout this paper. And today, Chair, we're really trying to seek support for the principles of our work, which are commitment to utilise the nationally announced ring-fence budget for dentistry by using some of the schemes referred to in this paper, commitment to the principle of a more innovative and flexible approach to commissioning of dental services above and beyond the national contract. And finally, whilst we recognise that the investment plans in this paper are before our overall position for next year, Lee, we would like to gather some commitment for the board to the principles of some of the schemes within there. So the paper notes the current challenges that dentistry in this country faces. I'm sure some of my colleagues might be able to expand on questions on this issue, but essentially we're facing the issues of a complex and some might say disincentivizing contract mechanism, although there is commitment within the national plan to review on that in future years. Like many services, dentistry is facing the challenge of COVID recovery. In South Yorkshire, access to dental services generally is better than national averages, but clearly it's not where we want to be. And there is significant variation across our geography and for particular demographics across our patch. Health inequalities in dentistry is a real issue. Equally in South Yorkshire, we do have high levels of poor oral health amongst some of our children and young people, and high levels of tooth extraction in secondary care. So this paper is a description really of the work that we're taking to address these issues. Debbie may be happy to answer, I say, Debbie, some of the technical use of the contracting, but we do feel that 2024-25 and potentially some of 2025-26 allows an opportunity of investment in innovative schemes designed to address access for our residents, and particularly those new patients who haven't been able to access dentistry lists and get appointments in the past. The schemes that we suggest link to the national announcements and the plan that has been published, and I would argue in South Yorkshire go further than what is announced in that plan. We will of course put a lot of work into evaluating the schemes, not only the use of the data but qualitative evaluation with our patients and our staff. In the first year that the ICB has had responsibility, myself and the team have put a lot of work in engaging with the dental workforce. It's certainly been an eye-opener, and I think that that engagement has been appreciated. Dentistry is well represented on our primary care provider alliance across South Yorkshire, and we also continue to make the best use of our collaboration across the three North East Yorkshire ICBs, and Andy and his team have been employed across our ICBs to look at the economies of scale where it benefits us most. One area where that is particularly relevant is on page 5 of the document in regard to water fluoridisation, which is by far the most cost-effective means of improving oral health. We're eagerly noting progress in the northeast of this country and have good political support across South Yorkshire in this area. I'm sure Sarah can answer any of the questions members might have about water fluoridisation. So I think it's important to be realistic. Things will not be sorted in this year. We recognise that improvement in oral health is a generational issue. Our longer term approaches to this is crucial. We also know that a robust and sustainable workforce is crucial to delivering this plan, and that doesn't come without its challenges either. A lot of these plans are despite the contract rather than because of it. And dentistry is our highest source of complaints and political queries that we receive to the ICB. But we do want to create a sense of optimism, both within our residents and our workforce, that some of these schemes will create. So, Chair, before opening up to comment, we'd just like to reiterate our ask of the board today, which is to note the contents of this report and confirm it is assured on the steps being taken to improve access to dentistry services. Support the intention to build on the current scope and good practice of flexible commissioning whilst being sighted of some of the risks. Agree the approach and commitment to dental funding, including a proportion of the claw, 25% of the clawback on a minimum 2-year basis. And finally, support the high-level principles of the 24-25 non-recurrent investment plan and giving permission for these to be developed.
I mean, I guess that's how, any questions? Sorry. Wendy.
Yeah, I guess it's about getting a richer understanding at place, if I'm really honest. So we had a bit of a conversation at our place option, but I'm just prioritise having a rich conversation about dentistry. so that we understand it for our neighbourhoods and what accessibility looks like and feels like for us. So I think we've had some sort of almost a bit of a balance, of course, by around on that, but definitely a priority for us to have a really, really good conversation about that, so we can understand the benefits and, you know, the drawbacks, what others can put into the space to, you know, lean into the challenges that we face, really. So I think I've really welcomed that, Debbie. I think they have to, you know, have that conversation in due course. And can I just check about the homelessness? Is that going to be, you said earlier on, are we able to roll that out across South Yorkshire, or is there any resources just for the existing pilot groups?
Initially, they've gone to the 2 pilot sites, which were pilot sites identified before we transferred over to ICB based on previous health needs assessments and evidence we had. So they've gone to those 2 areas. They're coming up sort of be a year towards the autumn of this year. And what we want to do is sort of see what happens with those, see the success, the outcomes of them. Before then we can then consider looking then to expand to Barnsley and Rotherham. I know we've had a lot of interest from Rotherham as well, from the authority colleagues, and similarly we're starting to get that boys coming over to us from Barnsley as well.
Chris, and then Lucy, I'll come back.
So thanks everyone, thanks Anthony. This is progress, isn't it?
I think so.
So I think what success looks like for me is as well, one bit for the place teams within our ICB is we don't have the relationship with dental practices that we do with GP practices. So if you were to ask me about the 28 practices in Rotherham, I could tell you the quality issues, I could tell you the access issues, I could tell you the public perception, the public and patient engagement groups, that activity. The dental practice, we just don't have that relationship at all. We did do prior to going to NHS England, and we need to get that back, don't we? So I think it's a case of how we work with the team to make sure we've got the South Yorkshire team working on dental, but also how the place teams working in partnership with the team.
Yeah, and capacity to do that, Chris. I think is something. Is that still good?
That's what I'm trying to say. It's
crucial. Yeah, we held a good dental event. I think some of the members were in this. That was in Rotherham actually, just before Christmas, and I do think actually it has been appreciated. We've gone out to the workforce really to understand their issues and get a realistic idea of how we can improve things. Many of the things that have gone into this plan have come from the local dental network chairs, committee chairs. So I do feel that some of that this is coming from the workforce rather than us. But I take the point, we need to do much more of it.
So creating a sense of optimism around dentistry seems like quite a bold ambition.
I'm with you on that.
I think we can safely say that for the people that we hear from at Health Watch, this is absolutely at the top of the list of the things that are impacting on people on a day-to-day basis. We've heard earlier about the different ways in which it can impact. So I think that messaging public around what the ICB is working towards and what they're trying to do is really important. Now we're having this conversation in public today, but quite honestly, the sort of language and the complexity around this, as you know, with the contract details and the different options that you have, it's really very dense and not really understandable to most people. I sit in a lot of meetings where I see different information and I still struggle to process what it means. So I think it's really important that we start to try and pull out some of the tangible actions that are coming from this and describe it in a really understandable way for the public and have this conversation.
Yeah, that with Lucy and Health Watch leads and it's also been raised in the event we had back in November. So I think, and one of the things we do need to do is make it in a more easy language that is really clear. I think some of the stuff that we get through from the national team is there and it has been used, but I think we do need to localise that to our South Yorkshire level. And then Sarah's worked with members of the comms team already looking at a particular population regarding learning disabilities in one place, but we want to build on that to duplicate that across place, but actually then utilise that information that's there for everybody. And so it is something that we recognise that we do need to do. And like you say, it is a very long report. It's very dense. It's got a lot of detail in there. And obviously now we've got the dental recovery plan and it's in the headlines about it's going to create this, it's going to create access, etc. We know there's still limitations within that if we're going to be realistic about it.
I know I spoke to you and colleagues, didn't I, Lucy, on Monday? So I think, yeah, we do recognise that, and it's something we do need to be looking at. We then work with the comms team within the ICB to pick that up.
Yeah. I suppose that's the other element. It does need a certain level of honesty as well, because there's, you know, it's all well and good to aspire to say we're taking action, and that's great. People need to hear that, but they also need to feel heard when they're describing that actually it's important for them. So I think an honesty about and a recognition of how difficult things are currently is really welcome.
Classic.
Yeah, I found this paper really, really helpful. So thank you, because actually it's probably something that I'm quite naive on, and actually it's really opened my eyes in relation to what it really means, what access really means. And this isn't just about trying to get a dental appointment, and that kind of link into the sort of population health challenges and improving access. I think it is huge. And I suppose just a kind of, I suppose, a bit of play as we go forward, and that kind of, I suppose what Lee was talking about earlier in relation to kind of understanding outcomes to help us to prioritise where we're going to focus some of those projects on around improving access, because this is huge. And you know, kind of in the utopia of the future, you'd really like to see this hooked into the family hubs, how that supports through the BSCE sector, where we might do women's or men's health, so that kind of that sort of access and opportunity to delivery for individuals in one place is, you know, we do that in the best possible way that we can, because I'm agree with Lucy, this is, you know, it's really aspirational, but actually we need to make sure we really communicate to our communities and our public what is achievable and how we're going to know where we've got there.
David, Moira, and then I think come back at the end and to Rob.
Yeah. So mine's very brief. Plans welcome. Do we think it's going to fix the whole problem? Absolutely not. You know, the driver for this is sugar. So when we work with our broader partners about food systems, that's part of, you know, sort of, can we turn off the tap? Really welcome the focus on children, because ultimately we have to prevent people from getting dental decay. We've got cohort people who we need to respond to their needs now. They've kind of missed that opportunity prevention. So just welcome, but put it in the context of it's still a big challenge for us going forward.
Well, then Lee, and I'll come back to you at the end actually. Is that all right?
Yeah, just a quick question about fluoridisation, and I don't necessarily need the answer now, but I noticed that it's been passed over to OHID and the Office of Disparities to address. So what is actually needed to make the decision about fluoridisation? Because we've been talking about this for quite a long time.
So up until the Health and Social Care Act 2022, it was the responsibility of the local authorities to conduct feasibility studies around water fluoridation, complex water networks. So it's not an easy thing just to do overnight. And they were also responsible for kind of for the operational costs of introducing new water fluoridation schemes, with capital costs being. With the new with the Health and Care Act in 2022, that responsibility now has transferred from local authorities over to the Secretary of State. So that's where the responsibility lies now for feasibility studies, public consultations, and the payment of the capital and operating costs. So in terms of where we're at now in South Yorkshire, prior to that, we had already done the feasibility studies to look at, to see whether it'd be possible to fluoridate the whole of South Yorkshire. And that report, so the has now been, as you say, passed over to the Secretary of State to further, so through OHID. What we're looking at now is a situation where you may be aware that the North East is going to be going out to a public consultation imminently to see whether the public would like their water fluoridation scheme up there expanded. We're doing a bit of a watch and wait to see how that goes. I think it's really important, though, that South Yorkshire ICB responds to that consultation, because that will have a knock-on impact to what happens in the rest of the country. Given that South Yorkshire is relatively ahead of the game in that we've got the feasibility studies in, there already, I see that we probably wouldn't be far behind in terms of water if the North East goes first. But they are the first area to to trial the new legislation and see how that goes through.
Worth saying something else as well. I can't remember the exact details, Sarah, you'll know it. It's been a massive length of time since a new fluoridation scheme has been introduced in the UK. So in a sense, getting the North East scheme off the ground and successful, we all realise is pivotal. And our intention, and we've had this conversation with political leadership in South Yorkshire, just so that you know, is we want to be next. But it really, I think if that gets through in the North East, and the law has changed, frankly, to make it easier because it's becoming almost impossible, we want to be an F for that. If that doesn't, we really are going to take stock, because I don't know how we will react as a country, not just locally. Is that fair? So,
yeah, I think it is. I think we need to recognise this will have could potentially have a huge impact on actually not just children, but adults as well. We know that children and young people in areas with a fluoridation scheme in place are less likely to be admitted to hospital to have teeth removed due to tooth decay than in areas without a scheme. If all the children in the most deprived 20% in areas with suboptimal fluoride levels, that's below 0.2 parts per million, instead received water with an adjusted level of fluoride through a water fluoridation scheme, then approximately 56% of extractions in these areas could be prevented. And you have to think, South Yorkshire has got some of the most deprived areas in the country. We have the highest levels of hospital tooth extractions. Financially, it makes sense. Looking at Lee.
thank you, Shaheen. Thanks, Sarah.
Just a couple of points really. One on just kind of workforce, and one of the things that worries me. I know we're just talking about NHS patients here. But I'm just really conscious that a lot of people end up having to go private. Yeah. But the danger of that is they go private, and that pulls in our workforce who go, oh, the NHS aren't paying us enough, but I'll go, become a private dentist because I can earn a bit more money there. So, and I know it becomes a really vicious circle. So I just wondered what we're doing to retain, not just kind of train up our dentistry workforce, but how do we retain them as well? I think there's that one question. Yeah. And I think just on the fluoridation one, just really quickly, I know we're talking about the North East and then hopefully we want to be next. There is that question about how do we tackle misinformation? Because the thing that's worrying me at the moment, we've got the whole issue around young children and vaccination, going for their second vaccination, etc., having to deal with a huge amount of misinformation around vaccination. I can just see that out of that consultation process for the North East, if we don't tackle articulating that information out there properly, that could then again become a whole misinformation thing.
I agree. If we go for fluoridation, there will be a whole consultation process, a lot of work we need to do. Absolutely. All we're doing today to the board, we've done this to the local leadership, we've done it with the mayoralty, is say, this is the direction of travel we will want to go down. You're absolutely right. There's a huge, I have got scars on my back from doing a consultation in Lancashire under the old system. It was really challenging. We've got to do this right. Tackling the myths is critically important. But the difference it makes in a health inequality perspective for children is extraordinary. The amount of children in this area who go for general anaesthetics for teeth extraction is staggering and worrying and frightening, and we shouldn't have any. Literally, we shouldn't have any. I mean, it really is a horrible figure when you look at it. Lee?
Exceptionally happy to support the paper, and I think it's really helpful, and thank you. A, because we're asked to plan on this basis. B, because it feels like return on this investment feels like moving high from a sort of health and social value perspective. However, just because it's hypothecated funding, it doesn't necessarily mean it's affordable. One of the potential reasons why we've got a deficit of close to 50 million in this system is we were quite good at spending this hypothecated funding on dentistry in year. Some of our other ICBs were not, and we're allowed to trouser that money candidly to bail out their underlying financial position. So there is something about just us getting in our consciousness, just because funding is hypothecated, it doesn't necessarily mean it's affordable. So notwithstanding that miserable endpoint, hugely supportable.
Yeah, and I do think this needs to come back to us with what we're planning to do in a more digestible form, should we put it that way? that says, now, here's what the money is, and here's what we're planning to do this year, and here's how we're going to measure its impact. Back to previous conversation. Lisa.
So just very quickly, thank you so much, and you know, the work is really welcomed. I think in primary care in general, we walk a fine line between fighting fires and prevention. I'm still old enough to remember people coming around school with disclosing tablets and stuff like that. How much are we thinking about prevention? Other organisations we can work with, so it doesn't include your workforce, so we can tackle that as well.
So shall I?
Yeah, please start.
So the oral health improvement programmes are commissioned by the local authority, so it's sort of separate budget generally from the ICB budget. And there are a number of programmes right across South Yorkshire. I think the biggest things that you probably have already heard of are things like supervised toothbrushing clubs. So we've got them in every local authority area, thousands of children taking part. In most areas, families also receive oral health packs through the health visiting teams for their children to introduce them toothbrushing at an early age, as soon as that first tooth comes through, and with that messaging around also please try and get them into a dentist as well as early as possible before their first birthday. There are a variety of other things happening, more place-based, but those are sort of the significant things I would say. Each area has an oral health improvement group chaired by the local authority, which is a partnership group. So it's people from dental services, but also voluntary sector, education, all sorts of people coming together. So there is quite a bit of work going on, but yeah, I agree prevention is the answer really to sorting out a lot.
So really helpful. Thank you very much for coming along. Really helpful. Strong support. Actually, bear in mind the curmudgeonly old man in the corner.
No, very happy to support, I heard.
Well, no, you think he's right. The board might not realise. One of the ICBs quite close to here, massively underspent in dental, which they were then allowed to put against their overall overspend. So, in a sense, we were more successful at one level, but it contributed to our 48 million problem that we talked about earlier. There's no difference, same money, guys. These are the difficult choices we have to make. I would like to come back so that when we're clear on the money, we can come back with a programme that we can look at and see, because I think people would value moving from this to, and this is the specifics of what we're doing this year. So when that comes to an hour, is in your hands. Is that okay? Yeah. Thank you very much. Thank you very much for your time. Good to see you. And we were planning a break, but I propose we go straight to non-surgical oncology outpatients, because I know that Julia and Patricia have just arrived. So let's go straight to that. Are you all happy with that? I'll take a break after. Is that all right? And I know some people are pushed on time. You're always welcome to stay. If you want to leave.
Nobody ever does.
Thank you very much. Nice to see you. Yeah, that was the right answer. Okay, non-surgical oncology option appraisal. Hi, come in. Right. Do you want to introduce yourself? I know you, but go.
So I'm Julia Jessup, Managing Director for South Yorkshire and Basketball Cancer Alliance, and I'm Trish Fisher. I'm an oncologist at Western Park, and I'm one of the clinical directors of the Alliance.
Welcome and nice to meet you, Trish. We haven't met before. Right, we've had a number of discussions on this in a number of places. Are you going to introduce this?
Yeah.
Emma, please.
So thanks very much for attending, both of you. Obviously, you've been publicised on this. Non-surgical oncology is a massive issue in terms of workforce, not just for us in South Yorkshire, but particularly in the north. There's a huge disparity between the north and south divide in terms of numbers of oncologists. And for those of you who are in the system in 2021, there's some temporary changes made to outpatients in some of the tumour groups, and that temporary change still remains. So we've been engaging in a process in the last 12 to 18 months, particularly thinking about engaging with our patients and stakeholders, and also our providers to figure out how we stabilise the current situation and whether we need to formally consult on any sort of future changes. So the paper really starts to look at the three options we've considered, the process we've engaged in, and what the potential outcome, proposed outcome is. So we've brought the paper here today for South Yorkshire Integrated Care Board, and it does span the, it's not just South Yorkshire, it is actually Bassetlaw and North Derbyshire we cover. So we are slightly different in our alliance. We brought the paper here today for consideration. So I'll pass over to Julia and Trish, and obviously happy to take any further questions at the end.
Thanks, Emma. Who's leading it?
So I was going to Julia, my backup. So I'm not going to speak to the paper because I know you can all read, but I would like to give you a bit more context and detail of the issues we've been having and the journey that we've been on. So oncology are almost victims of our own success, particularly as a lung cancer doctor. I've gone from having very little to offer people to having multiple lines of treatment, much safer, kinder treatments that I can give to much older, frailer people, and much more combined modality, very complex treatments that take a lot of time and effort. This is all wonderful. However, our workload is going up like that at the same time as our workforce is collapsing. And the Royal College of Radiologists, which does a very detailed census every year. Currently, we have 17% of oncology posts across the UK unfilled. That's predicted to reach 26% year. And the next census will be out in the next couple of months, and we're all holding our breath for how much higher that figure is. As Emma's described, there is a very distinct north-south divide, but even in the south of the country now, who have almost double the number of oncologists, they cannot cope with their workload either. So we have been on this journey probably longer than lots of other people. To add to the problem, NICE churns out positive appraisals for a new 40 or 50 oncology drugs a year. It doesn't tell us what to stop doing, and up until recently hasn't acknowledged that we need to consider the infrastructure that underpins any of that work. Trying to develop a new system, how successful that will be, we really don't know. Our hugest issue is breast cancer, because it's 40% of our oncology centres workload. These ladies, even when they've got metastatic disease, have multiple lines of treatment and can live for many years. Our breast oncology service pretty much collapsed. Firstly, partly COVID. We had a lot of overseas people who went home. And then we were too reliant on locums who all decided we were working with them too hard. And because they only have to give 5 minutes, they just drop a hat. So in September 21, we had to consolidate from going to all 5 localities. We couldn't manage that. Within 6 months, we had to go down to 2 localities, which is Sheffield and Leeds, places in Rotherham. And even that, we felt that we could no longer safely do. So in March, April 22, SPH declared a critical incident on the grounds of patient safety. So all of this was done for patient safety. We had to do something very similar for our other big tumour sites. So urology has been 3 sites since COVID, and lower GI also went to 3 sites at the end of 21. Lung has been the only team until recently where we've had a common tumour group who have visited all 5 localities. However, prolonged consultant sickness earlier this last year, we're in 24 now, demonstrated that the lung team wasn't resilient either. So we're now looking at reducing lung from 5 sites to 4 sites. We're trying to learn a bit from what we've already been through in terms of where those sites should be on population health reasons and what escape is available to us and where. We've tried also to put lots of mitigations in place for the people affected. So, for instance, we've done a huge piece of work pushing chemo delivery locally, particularly in Barnsley, where an awful lot of the patients were travelling into Sheffield for their treatment, even if they were seen locally. We've looked at transport, which is often a big thing for people, and with the charity, we've been able to do things about that. And we're trying to make the virtual offer really good in terms of not just a telephone call, but a supported video consultation with your oncologist. We know that we've done the work in tumour silos almost, so breast have done their bit, colorectal have done their bit. What we need to do better is looking at what we're doing for each place and the system overall, and that will be part of the next piece of work. But because we've had a temporary situation, we've had to keep going to JOS every few months, and we've been so focused on the stabilisation and getting out of having to report to JOS that's consumed a lot of our time and headspace. So what we want to do now is draw a line under what we can safely deliver at the moment, which will allow us to have sensible conversations about the SLAs, which are very inhibitory for moving things on, and to move on to the proper transformation, what we really want this to look like, so that knowing that we have a workforce that isn't going to grow, how can we best serve the population? And bearing in mind that the outpatient model is quite a small part of a very big jigsaw. And the other key things underpinning the work we're doing are looking at our acute oncology ETDEC model and a huge workforce piece of work. We've done a great deal of skills mix. We are probably ahead of the country in a lot of the oncology skills mix. But again, we need to unpick some of that, learn the bits that are working, work out where we can go faster and do more. So it's a very, very big piece of work. And what we're asking for at this stage is recognition that we've got to where we've got to, not ideal, patient safety grounds. We just need to consolidate and then we need to move on. Unfortunately, I've just stopped talking. I'll make this go away.
Next. So what do you want from us today?
So we're hoping that you're happy to approve the paper that we've bought with the consolidation that's nearly there. Just that last piece of work around lung cancer, which is in train at the moment. The clinical teams have described what it is they need. Joint Rotherham and Barnsley clinic, and the localities are coming back with whether they can provide that for us. So once we've done that, we want to draw a line under that so that we can actually start really thinking about what we want rather than what we've had to get to.
David and then David.
So I think I chaired the meeting in this room as the Committee of Clinical Commissioners when, the crisis first started. And I think, credit to the team to maintain a service across South Yorkshire for the specialities that's there. So I suppose it's just for me personally as a clinician, I fully support this. I'm involved in Cancer Alliance. I've seen it, I've been on the journey the whole way through this. And as Trish says, it's not kind of where we want to get to, but there were times through that period where we thought we weren't going to have any service at all. So, it has impacted on people and it will have some effects, but ultimately managing to maintain it at this point seems like a good outcome to where we thought we were going to be.
Which then rest.
Yeah, thank you.
And then Wendy.
I echo David's comments from the acute perspective in terms of how difficult it is to manage. It seems to try and pull together to get a solution. And I was at jail school SOC when this was presented, so I listened intently to the debate and understand why this option is the third option. It's the option that we all feel support. My comment really is about the final bullet point, which is it's often key pivotal point when you get to a position like this about what the next steps are. So I think part of the work is what will be the cancer, the oncology, the diagnostics model moving forward, because Trish has articulated, exactly why the cancer services are under such pressure. It's a two-pronged problem at the moment, that each prong will need managing, but we know the demand is going to increase, and we know that modalities will change, nice guy, but the demand will increase. And as a result of that, I think it takes us back to the earlier discussion about how do we make sure we do the right things right and stop doing the wrong things. And so for me, one of the things I think we should do is work out what our long-term strategy is for cancer, oncology and diagnostic services and make that part of the plan. It's one of our biggest areas of work, and it will be one of our biggest areas of growth, and therefore we need to think now how we're going to deliver it.
So just to come back on that, we are looking at developing a cancer strategic plan at the moment, and it focuses on three elements. One is prevention, one is world-class outcomes, delivering world-class outcomes, and the third element is around advocacy. And so we're not that we're in talks with lots of different organisations, but you're right. And actually, it's not just about cancer; it's about acute service reform, because actually, cancer diagnostics isn't just around cancer, is it? Yes. You're absolutely right. So we're thinking about that space at the moment. Try and get a model that we think we can attract a workforce that wants to stay. and then we've had looked at multidisciplinary elements. So you're absolutely right, Richard, it's part of our sort of dialogue going forward.
And just touched on it in the workforce challenge we have in oncology, it's absolutely mirrored in pathology. 20 or 28% vacancy happening to pathologists who are part of that diagnostic process. If we don't wrap it all up and make sure it's clear, challenges will just get more acute.
I've got Leslie and then I've got Wendy and then Leslie.
Thanks. Thank you. I know how hard this has been and the work that's gone into it because I've kind of tracked it over the past couple of years. So thank you for that work. I almost feel the point I'm going to make feels a bit churlish, but I do think we need to think about governance because we were aware of this work through Quality Patient Public Involvement and Engagement Committee that I chair, but mainly in the context of the patient engagement piece and not in the terms of the patient transformation element necessarily. So I think this was the first time I'd seen the proposal in its entirety, and I would have wanted to see it before, I think, particularly from the aspect of inequalities of access. Because when I first read it and I read the locations, and I understand all the constraints people are working with, but it felt very Sheffield centric. And when you look at it, you know, if you're reading it as a member of the public, you're thinking, hang on. Now I appreciate that public consultation actually supports the work that's been done, and the public consultation element has been quite substantial in this and very good. So I think we can be heartened by that. But I think nevertheless, there's a story to tell people about why that decision's been made in that direction, because it does look like it inhibits access. And I wonder when we're moving forward, two things really. One is it'd be really good to see the equality impact assessment in full, because we've not cited on that. And the second is that as we move forward and we think of some of the criteria, just think that equality is having that in the criteria that we're considering and looking at that very explicitly would be helpful in the next phase. So I'm not saying I don't support this, but I think that, you know, because clearly people worked really hard to get us to this position of stability, and it could have been very wrong otherwise. But I think as we're moving forward, trying to work on that would help us.
Can I just pick up the governance issue as well? I think we need to do some work ourselves. Where does this go? To the ICB alone? That's not for you.
No,
That's for us.
I agree, because I think for people doing this kind of work, the landscape in terms of governance is very complicated. And sometimes you think you've done all the right things, but you might not have. So I think you're right, Piers. I think there's still some work.
Can I go to Wendy and then come back to Julie and then Will and others? Wendy.
It's what a tough journey, isn't it? It's been incredibly difficult, and I really do appreciate that. And I'm sure bringing even the stabilisation offer in, that's been a tough gig to land, even bring that forward, really, for all the reasons you described and the paper describes. I guess from a Barnsley perspective, for Barnsley, really, you'd be no surprised about what I'm going to say, really, is that I'm really interested in understanding the Barnsley voice in the engagement today, and really helpful for sharing of that. In socialising the proposition more broadly across our leaders in place, they were quite worried and anxious about even the stabilisation phase. And again, I'm sure you'll appreciate that. So being able to try and understand, so what mitigations are going to put in place, given that, you know, we all know from the Health and Quality Report, as the most challenged neighbourhoods in Barnsley would be those individuals that would be least able to afford transport. And Barnsley is not a very well served town for transport, I have to say that. And therefore I'm really trying to understand really for us, so what could that look and feel like for us, even in the short term solution? So there's something for me to be able to take place leaders with us on this journey, because it was a pretty difficult conversation that I've had this week, even on terms of the stabilisation proposition. So being able to pick that up, and I would quite like us to note, inform, I think in the minutes, Barnsley's very particular anxiety about stabilisation phase, but accepting that as well. Further conversations during the post that we could have about understanding that in a little bit more detail.
In Joel Squeed, the Barnsley representatives have raised the same issues. And as a lung cancer doctor, I'm very struck by the difference between what we've done for total lung health checks, which has been rolled out to the most deprived bits first and Sheffield last. And in fact, if you look at that, we're about to make the most deprived bits less able to reach their lung oncologists. What I would like to do is actually take some stuff out of Sheffield and push it in the Rotherham Barnsley direction, or even relocate it from the central campus to the northern, make it easier to get to. So that is what I was hinting at when I said I think that we have got the system distribution correct, because a lot of what's happened, because it was acute, it was patient safety, it was driven by the oncologists, and actually I don't think we've had enough challenge from other places. And I actually got the thoracic surgeons and the chair of the lung CDG to come and challenge me about why I was switching Barnsley and Rotherham together, and therefore one of those locations was going to have less access, and they couldn't come up with a better plan within the current constraints. But I absolutely agree that we have to think very hard about that. We have, particularly for Barnsley, really made a difference in your ladies in particular not travelling for their chemo. Up until recently, I was also a trustee of the Western Park charity, and we were very keen to get transport into Barnsley. It took a while and a bit of help from Power, I think, to get that launched. But yeah, there's much more we can do about thinking about what the final configuration is, based on where the pockets of need are for the different tumour sites. And I don't think we've laid that over at all. We've begun that discussion, but it complicates things, and that's why we need to draw a line under this and get to the place where we can describe what's correct.
Yeah, that's really helpful. I mean, it's just really helpful if you could, share with me some of your sort of strategies around, how we're going to track the impact of this short-term proposition, even accepting everything about you said about let's co-design the future state. What really, how we're going to track the impact of this on Barnsley residents, and what mitigation we're going to put in place to really support the most challenged neighbourhoods, and that's been really helpful for me.
Julia.
So just to add that, so there is a full EQIA which we're happy to share, and I think that is scheduled for quickly, Leslie.
Yeah.
We just couldn't get it in sequentially. So that is scheduled. We will share. In terms of, we will absolutely track access. So as part of what we're doing, we can understand which populations are accessing chemotherapy. So we will keep that cited as good as we're moving through. I think the other thing, Wendy, from a Barnsley perspective, we have invested in Barnsley to really develop the virtual offer. So looking at that outpatient offer, how do we get so currently the virtual offer is telephone, and what we're having a look at and testing with Barnsley, how do we get a clinic space that allows DNS, all the holistic wraparound care to be done at the local hospital, and video conference and oncologist in. That's a model that's operating elsewhere, and that's what so we've invested that funding Barnsley to say how do we get this right there first. So that's one of the things that we're trying to do. As well as Trish said, in the round, we're making sure that we are giving more chemotherapy delivered locally, which is the vast majority of the journey, and also looking at the SDEC model, so the acute oncology model. So the totality is more services local, but totally accepting on paper this doesn't look as though it's a health inequalities-led piece.
I've got serious people. Shahida, then I've got Emma, then I've got Kevin. Shahida, and then Lee.
It was more of a suggestion around the public transport thing. Just thinking of Mayor's plans around franchising the bus services. I'm wondering if there's a suggestion there that we could make around linking that to health and accessibility, because at the moment it's just looking at from a cost perspective on kind of accessible routes and reinstating some of those. But I'm just wondering if there's a question. I'm just thinking through the ICB partnerships and strategy to push that forward and say, well, actually, can we link some of the franchise model and overlay that onto our health model and accessibility? There's just a thought.
It's a good thought. I do know that we're at the foothills of the franchise model. I think it'll be a couple of years before the formal changes happen. I think the Mayoralty would be really up for this discussion, but I think they're a couple of years away from the actual change happening. But it's the kind of stuff they do want to pick up as part of it. Emma.
Yeah, just to come back to your point, Wendy, I think we have tracking on health and wellbeing boards in Barnsley, but again, because of the frequency, we've not managed to. We have in others. So what I'd say is we're more than happy to come and speak to the Place Partnership in terms of that and now what we've done. The kind of, the conversation we've had numerous, and if that hasn't been shared, then, I take responsibility for that, but we can do that. I think, this is not something that's going to be in isolation. We're going to have many more of these discussions because of the fragility of some of our services. So I think there's a kind of learning from this is, so how do we do that, in a more community way. But as you said, people are sort of really trying just to kind of keep this, our focus is to try and make sure that and access in South Yorkshire. And that has been quite, quite difficult. And I want to thank Trish, particularly around her clinical leadership in this space, which has been absolutely fantastic, supported by Julie and the team. So I think we just need to think about this because I think it's really the start of some of these very tricky conversations, not just related to cancer, building on the work that we should refer to. So I think my offer is, we're happy to come to the Place Partnership in Barnsley, talk through that health and wellbeing board as well, and actually, in terms of quickly, etc. How do we think about how we frame some of this in the future?
Can I, so it's just one point which it's difficult to reflect in the paper, but I suppose in order for us to move on and do the transformation, we all know the hearts and minds were absolutely critical to seeing this through. And I think the stabilisation phase and where we've got to now is we've got the oncologists behind us. We have plugged the leaking hole. They are supportive of the approach, and I think generally in the work that we've been doing now around how do we get to the improvement, you might reflect back differently in terms of what we're getting is this feels a doing together piece rather than a done to piece. And so it's hard to describe that in a paper, but I think we have moved mountains in terms of hearts and minds.
That's a really important point. This is about, if we're going to change this going forward, we need the hearts and minds of staff with us. And if we've got them there, we don't want to lose that. I accept that. Kevin, I believe.
I think each of us individually have to preface everything we say by saying what a tremendous progress has been made. I think when David chaired the meeting back in September 21, I think it paid good money to be in the position we're in now, given the context. I think that's really important. I think place buy-in, not just Barnsley, is important. And I'm not sure what the Doncaster view is, for example. I think that's really important in terms of finally endorsing this. Our populations tend to be fairly healthily in the main, but sometimes unhealthily sceptical. And then when we do things on the back of patient safety, people will default to, well, that's it then, isn't it? And I think there's something here about in the narrative. This isn't a full stop in some things. This is a comma, and I think we have to work hard to persuade the people of South Yorkshire that actually there's a real intent, because people will fear losing local services. You as professionals, people as professionals, staff who work in the service will see that it's the right thing to do to maintain that service. It's not easy always for our population to understand that. So I think there is a narrative, and we need to be more persuasive about this. This is a comma, and there's more work to be done. And certainly, I'm pleased to hear that the quality impact assessment has been. Bearing in mind your opening conversation around how important this is to us, we just need to fully be assured that there's nobody disadvantaged.
And then Will. Thanks, Trish. I think some of us recognise how difficult this would have been in the clinical leadership sense. I just want to say thank you first of all. I just wondered what a sort of proactive oncology strategy for South Yorkshire looked like that wasn't a kind of continuously reactive one, really, and what support it would take to get us into that place. Really, it feels like the demand is going to go up, the supply complexity is going to go up, and candidly, if we've got X oncologists, whereas the South of England, whereas they're less needed, has got 2 X consultants, it doesn't feel like this is a particular soluble issue. So I just think we need to think through how do we scope what a proactive oncology strategy looks like. And I think we've got to challenge ourselves as an ICB about we shouldn't just accept we've got X oncologists in the South, they've got 2X. And what are we going to say about that from a sort of spatial and regional inequality sense? because it feels like we've got the medical workforce in the wrong places from an equity standpoint. So I think we need to think through about what we say about that, because I don't think we should just walk on by it.
Yeah, thanks. I just had two comments really, and Trish eloquently covered one, which was I was just reflecting on the strength of the commitment that there is in terms of the ultimate model to do something different that's right for our communities, recognising the health inequality. And I sit here sort of having a lot of confidence in that, because I've known Trish an awful long time. I've also I came to work in South Yorkshire, and the first thing I did was cancer. So I've seen it completely full circle, where we've actually with support of the services in local communities and local hospitals. And I know that there's always been that sort of challenge, hasn't there, around the workforce, whether it's oncologists, histopathologists or physicists, that really mean that it's really challenging, and we've really advocated to hold on to the model, but unfortunately we've got to think differently. But I do think that I absolutely feel confident with the strength of commitment around that. Second bit was on the governance piece. Just recognising all of the learning that we're in, but I think it's really as an integrated care board, just thinking about where we are now, because our Cancer Alliance is probably our most developed, mature alliance that we have. It's Cancer Alliance, actually it's all about partners, membership across the whole of the piece, and it's doing some great work for us. And therefore, I'm in the space of, if we do a bit of a sort of thinking and review piece, it's actually, I'm thinking at it, what do we need to do to support the Cancer Alliance to do more of that? Because our system's really complex. It ain't easy going around for health and wellbeing boards, health and care partnerships. So I'm in the space of how do we make sure we do the work well, and we do it efficiently and effectively. That's what we're trying to do. We empower the Cancer Alliance to do the work that it's been doing for 20 odd years in different guises and been doing really well. How do we, in this, in the time of integrated care systems, integrated care partnerships, being really joined up, how do we do that well?
Sorry. Really helpful. Let's people comfortable we go forward on this stabilisation plan as a basis. I take it that we are. Great. Julia, Trish, can I thank you both for coming along for the work that you've done. I do not underestimate the difficulty in this, genuinely. So thank you very much for your work. Happy to support it as we go forward. I think the real challenge for us now is to develop something that a flexible plan that really thinks about the issues we want to pick up. But I know you're committed to that. So thank you very much for your work. Thank you. You've got agreement from me. I'm going to propose that we take a 10-minute break before the next agenda item. 10-minute break means it is 12:02 when we come back. Like, you'll take any notice of me?
Come back, you say? You're not in provision now, Richard.
If you want, like,
What do you think if Philip's done that?
That might actually we have nothing in our house.
I'll get that and then like again.
They should do.
So we've got some energy drink in our house, we haven't had it for weeks. And then the it lasted for weeks more. We've gone out for a meal. Then the bottom of that drink out for quite a while. Picked them out, for example. And everybody else got a fizzy drink, but it was so funny because just looking at it made me think, and I was like, I'm so weird. I was like, it's not just being up about, you know, melodramatic. All this and then you've been decided like that.
That's why I
I had one cigarette last week. I had one cigarette, so I was the kid, because we have to take this. Really well. And it's we've got it. Just a few months ago, literally, probably I'd say now, action's gone. When people see him now, it's like, and he was on his meeting. It's quite the level point and the other week he
Well, we didn't take it though.
just ruining it.
You would have had those conversations. And kind of, do you want to come back? Yes, please.
Well, you'd have felt more, was it that he was, would have been answered.
There would have been answered in that way.
It'd be nice to do it without. So just black and rely on
I agreed with Jodie that I thought TV states were also writing an email. I'm sure Levy's probably flagged it straight away, to be honest. Yeah. Some basil.
So what we're saying, another Friday. Maybe just say there will be quite decent quality. Well, yeah, we did wait together.
You are getting.
Oh, actually,
NHS specialist. So it's like trying to be.
Yeah,
No one's saying this.
Some 6'1", don't They give you 3 for affiliating at all. There's like the laptop way.
I've also been getting very close to being one.
Because they won't get paid.
What difference in terms of Can we start? Right, can we start, please? I am trying to finish. I love the way I get total silence, right? You know, it's kind of touching. And anyone who thought I was important has just learnt now that I'm not. Okay, I am anxious to finish at 12:30. There's some people are going to leave, so that's it's not just me being difficult. Although God knows I am. Okay, item 12, integrated performance report.
Thanks, Chair. So what I suggest is we don't touch on finances. I think we've had some more already on that. I think probably just pick out some headlines around quality, operational delivery, and people. But let's start with quality. It's not quite the order on the agenda. Best place to start. So David and Catherine, is there anything that you wanted to raise, particularly from the IPR with the board?
So Gavin, I do. If you had it in your introductory page for about measles, I'd like to just raise that because I know the comms team are about to launch a campaign on the back of the national campaign. So people will be aware that there's been some outbreaks of measles across the country in the Midlands and then in London. We're not immune to it in South Yorkshire, so we haven't seen the same numbers. I think each of our 4 places have had sporadic cases. So, you know, what's the campaign about? Well, the campaign is the best way you can protect yourself is to immunise against MMR, and we have seen levels of taking the vaccine sort of dropping off through COVID. And you know, if we can reach a high level of vaccination, we all benefit. So not only the individuals had the vaccine, but your family and vulnerable people who might not be eligible to have the vaccine. So I suppose a single quality issue I'd like to raise is with regards to that. I think within the performance report, we touched on UEC a number of times today, and it may come out. But you know, the reports from November, and kind of in March, so just there's a little bit dated on that. And with providing element of the BBC report, there is a big focus on it. We continue some daily meetings and ensure it's been set up to do what we can to support the system to respond to that. So those are the two main things for me.
Yeah, I suppose I just kind of wanted to give a bit of an update in relation to kind of metrics and reporting and what does that mean in relation to what we might bring through to the ICB board. So we had a kind of an hour, quite an hour, not like an hour, and on the last board development session, just in relation to the statutory responsibilities, what data and information have we got available, actually, how does that link into the other information that already sits in our RPR? And David and I had a half day with Leslie to start thinking about actually saying what's Quippy's role in kind of bringing some of that information together, and then what needs to come through to the board. So there is still a space that there's a hold page in here for quality metrics and working with Kieran's team in relation to kind of what does that need to look like? Because actually for me, when you look at the IPR and you look at those kind of headline keys across the top, which is health and equality, prevention, maternity, community health, UEC, primary care, MHLJ, each of the metrics within there are around quality and safety services. So for me, there's something around how we really define what else needs to come through, what's meaningful then for us from a board perspective. So that works still ongoing. Nothing particularly to flag from a maternity perspective. I think the updates in there in relation to kind of where we are in relation to sort of CMST, saving babies' lives, progress. We've brought all of that from an assurance perspective around process through Quippy in the last month. And again, having some conversations with Kieran's team around what data we use, because at the moment the data we kind of bring through is the Embrace data, which is 2 years out of date. So it doesn't kind of help. We look at more sort of real-time data, which is part of the LMNS. So kind of what do we bring through that makes sense in that? And the other thing I was just going to flag was sort of the national priority and plan for the rollout of Martha's Law, which people might have seen in the press and in other areas, which is around sort of the prevention of deterioration of patients in the acute care setting. And that's just really being launched following sort of consultation with families. So we're starting to do some scoping work around what does that mean for South Yorkshire, what have we already got in place in our organisations, and which of our organisations may be making that bid as part of the first 100 trusts to be part of the accelerator programme about that. So I wasn't really going to flag anything other than that in relation to this sort of progress, but two key areas that are sort of on the horizon.
Christine, do you want to give us some headlines on work?
Yes, thank you. So I think the key metrics that we pull out around absence, vacancy rates, agency and bank workers all show a downward trajectory, which is really positive for South Yorkshire. You can see that the agency has dropped off quite significantly, bank less so, and that sort of indicates that we're changing the mix of our contingent workforce across South Yorkshire. So moving more to bank than agency, which is also positive. And the main reason for our agency spend at the moment is vacancies, covering vacancies. That is about over 40% of the reasons for agency workers. I think it's important to know we've been talking about the workforce data for quite a while. I'm working with Richard Parker, Parker Support and Kieran. We are proceeding with getting an ESR nightly feed now for all of our NHS trusts across South Yorkshire. And working together, we can therefore create bottom-up a data set that I think will help us determine, more effectively what KPIs we want in this performance report going forward, Gavin. So I just wanted to report that we are making good progress on that.
Thanks, Christine. Mark, on more general operational performance.
Yeah, of course. Just more kind of specifically on where we are to kind of embellish your case beginning, really, Gavin. In terms of the impact of industrial action, in the period that the report covers, more than 300 hours have been lost in kind of clinical time, which has been a significant impact. In terms of urgent and emergency care, as David highlighted, we are relentlessly focusing on the 70% 4-hour standard, and that's both a local response and a regional and national response. And the ICB partners and colleagues are participating in more than daily calls. So we've got a battle rhythm, which is the terminology which is being used to track and monitor delivery for our standard at 10 o'clock during the day, at 1:30, at 2:30, and then there is a regional call to national at 4 o'clock. So there's really quite enormous scrutiny on the significant work that's being played out by partners at this time. Our delivery, the improving trend, we are around about 71.5% in the month to date, which admittedly is about 4 days, but that's a significant improvement on our January performance, which is in the report at 66%. So whilst the small wins, they're really hard won, and I kind of wanted to just celebrate them. In terms of the elected position, Gavin has already highlighted that, but we are tracking, and our partners across the system are tracking individual patients who are waiting for a significant amount of time, and we've seen a marked reduction in the number of people waiting over 78 weeks. It is less than 99 mid-February. We're now tracking on an individual basis 60 individuals, 31 of them are waiting for corneal graft. Challenge with the corneal graft is the availability, as Gavin said, of the donated material, working to ensure that those patients have got treatment plans throughout April, subject to the availability of further donated material. And then there are a small number of complex pathways, complex patients who we are tracking to ensure that there are treatment plans in place during March to achieve the objective. We've seen the number of people waiting over 65 weeks and over 52 weeks. Once it had spiked at the impact of following the impact of industrial action, that is now starting to reduce again. We're tracking towards our 65-week objective, although we start a cohort of patients waiting at the end of March. In terms of cancer, the faster diagnostic standard was achieved during December, and then Julia was still here. She'd tell you about the actions that are in place with colleagues and partners and the Cancer Alliance to track delivery throughout the remainder of Q4. 62-day backlog, we're around 140 cases away from our objective. The significant impact of industrial action, and that relates to shifting hospitals, urology and robotic capacity. So there are plans and actions in place to mitigate all of that, including support that's been secured over the last number of months, around about £500,000 to support additional activity. And then in terms of the mental health and people with learning disability and autism, you can see that we've got a bit of a mixed picture really, and there's further to go at, and there's more to do, I think, around addressing some of the challenges around improving access to talking therapies. Whilst there's been great reduction in the number of inappropriate out-of-area placements for mental health patients, there is still a cohort of patients who end up out of area, and so there's still a focus that needs to be carried forward throughout Q4 into the financial year. I think that's all I've highlighted.
Oh, that's it. Okay. Any questions on the IPR? Thank you. Corporate assurance report. Oh, sorry, I didn't see that. Who was the question? Sorry. Kevin, I apologise.
It's okay. I'm conscious of time, but
No, you're all right.
Moving on from the impact, which is important, and the mental health focus. I'm just wondering whether we should be concerned about the NHS talking therapist performance of 46%. It seems, from memory, it feels much lower than it has been in the past. Now it's a nationally prescribed model, and it doesn't take account of what all doctors may be available to patients. But is it a concern which needs to be escalated? Have we got a lot of people in the system who require support or are not able to access it? This is what this indicator is telling us.
Mark, did you want to come in?
I was actually going to raise it as a query anyway outside the meeting. Because actually, if you look at the South Yorkshire total, it's 46%. But if you look at it by place, the minimum is 81%. So I'm not convinced the calculation is correct. So I think we need to check that.
Okay.
Well, if it was 46%, you wouldn't use it. I would have an issue, but I don't think quite stack so.
Okay. Thank you, Mark. That's helpful. Lucy, I'm sorry I missed you as well.
It was just to come back to the point about measles and the work to promote vaccine uptake. So we had a lot of learning in COVID about how to work with communities to do that, and I just wondered whether or not we were taking that learning into this bit of work.
Yeah, so we work hard with the NHS England teams who still have responsibility for the measles part of the vaccination immunisation programme. But what we have got now, Lucy, is the same level of detail by primary care network and demographic that we have for the COVID work. So we know that, and as you can imagine, there's a big amount of variation across South Yorkshire in terms of take up. So the work's going to be very much within those communities most at risk.
So when you say in those communities, you can work proactively.
Yeah, with practice, and also with practices who are doing it.
And it does affect people disproportionately. So we know the people with the lowest uptake of vaccines are the communities that we need to work hardest to work with. So say Anthony chairs the Back and Inns group, and so I think it's multiple initiatives in place.
Yeah, just to pick up on the MMR vaccination, we've had a GP practice in the north of Sheffield that have reached out to our organisation, particularly on the kind of second vaccine uptake. So they had a really good kind of impact on getting communities and with young children for the first vaccine, but have then seen a significant drop off for their second vaccine. But I think just going on to your point about kind of the different ways of working with communities, I think part of it was around tackling misinformation, part of it was also about some of the things that we did differently in COVID was about kind of empowering community groups in a way that was not just about tackling misinformation, but those kind of really deep dive insights that they had into those communities and kind of what some of the issues were that they were dealing with. But because they were more empowered to deal with it, they then were working in a kind of a stakeholder model with all of the partners, had quite a significant impact. So like I say, I think for 1 week, South Yorkshire was doing amazing on the COVID vaccines, but that was because we'd taken that different approach. So if you want any learning from that, Anthony, we can push that again. But it was interesting that the GP practices that got in touch with us got in touch because of that model. So they kind of said, oh, that worked, we're struggling. And then they've reached out. So I think it's just something to consider that we might need to go back to stakeholders that we used during COVID and take that different approach again.
Thank you. I mean, we do have a vaccination board later today, actually, so I'll take that down.
Thanks, Wendy.
Yeah, just follow up on Mark's contribution. Another point of accuracy, really, because I don't think the LDA health check figures is right either in the pack on page 119 of the PDF pack. I think we're on track. Overall, but I understand there's a data issue, so it might be for this combo.
Okay, let's pick that up. But it does worry me that we get queried about mental health data, and that's a broader issue, isn't it, about how well that's counted generally in the NHS?
If I could Chair, we'll take the accuracy question away. I think some of it may be presentational as well, because I think we've got a mixed economy of in month, so the December position and then the cumulative position, which is quite different, but without it being kind of marked up, it's kind of hard to demonstrate.
Thank you. Okay, thank you. Corporate assurance report.
Thank you, Chair. So I present the report as read. I just wanted to highlight 4 key areas and potentially bring Will in around the Bath and Risk Register work. So corporate assurance activities in the last 2 months, they're kind of enumerated within the report. Register of interest have been updated, they're available online. There's been no use of the corporate seal. I know where it is absolutely currently, because it's going to move from this building to our new building. We've had 8 subject access requests and 82 FOIs within the period. So that's within 8 weeks, we had 82 FOIs, bearing in mind we've had Christmas and New Year as well. Various kind of statutory and required meetings have taken place. In terms of complaints, as part of our implementation of the organisational change programme, a dedicated single function has been established. We've fully populated that now through the organisational change programme. All people are in place. All bar 1 person has started on Monday in the new team, and the final person joins mid-March. And we'll work into the implementation of the new model. So we'll have a we'll have a team of 8 whole-time equivalents who will actually be, I think that's about almost 5% of our ICB workforce dedicated to the complaints function and pursuing some elements of company inquiries. In terms of other items within the corporate assurance report, the SFIs, standing financial instructions, went to the operational executive and then to the audit and risk committee and are now here for approval and ratification. And we've just gone through a process of due review and update. There were 2 minor changes that related to some very minor elements of audit and actually wording, and so they're presented for approval. And the final element to bring the board's attention to is the board assurance framework and the risk register and issues log, including some development work around those elements that are outstanding, and that's brought for the board's attention and to give assurance of internal processes around risk and risk management. There is an ongoing review of the board assurance framework and risk register in light of our new strategic objectives and context in the joint forward plan, and because we're at the end of financial year, which will go through due process, but I don't know, Bill, if you wanted to say anything about that.
Well, I thought I'd be here sort of not highlighting the fact that the timeline that has slipped, but actually the team have done a great job actually in terms of moving forward the work. So I last progressed doing a bit more of a wholesale review of the board assurance framework in Q3, which did start. There's quite a bit of work to do from that. The team have progressed that, and I think we should be able to complete that before the end of the financial year. So there's some final steps within that, which does involve some of our risk owners as well. So I think I'm reporting positively on more of a sort of update of the review.
So when the report was produced, we haven't had quickly, we had quite a lengthy discussion about that indicator 1.1. And as the report suggests it's 9, we've increased that to 12, given the environment of operational and financial and instability and the number of sort of quality concerns that are being highlighted. So I think just to update the board on where we are, that's reflected in the future report, but we've met after the papers have been compiled.
Okay. Helpful to know that. Thank you, Dave.
Just a minor note on the BAP. It's informed that we're seen to adopt a new BAP formally from the 1st of April. So it might be something you want to take in formal.
Okay, thank you. Thank you. Are you happy to approve the revised SFIs? Item 14, safeguarding adults and children's policy. Catherine.
Yeah, so I wasn't particularly going to say anything about the policies. They're here for board approval. They've been through OE, and actually we have a safeguarding oversight and management group where the experts that know what they're talking around this agenda around the table to support and review that. So it's been through the internal governance processes. It just is here for sort of final rubber stamping. There are a number of policies that will be coming through over the next few months because we've been in the process of aligning those across South Yorkshire for us as an ICB.
Okay, thank you. People come through with that? Maura, yes, please, and then Wendy.
Yeah, I mean, just a very general point. I mean, it's very welcome. I would just like to reiterate the key role of ICB representatives on safeguarding adult sports, particularly. I know they're on children's as well, but they are a statutory partner under the Care Act. So, really welcome this and continued support for the multi-agency approach to this. I know this is an NHS policy, but obviously in a wider context of multi-agency working.
Wendy, thank you.
Yeah, it's just very practical, but really helpful just to table these on the children's safeguarding goals in place of one safeguarding goals. So eventually do that.
Thank you. Everyone come to with that? Approve them. Thank you. We have a series of minutes for noting. So just for noting, is there anything anybody wants to pick out from any of these? Anthony.
Just very quickly, Chair, in terms of the ICB place committees on enclosure 17, just from a Doncaster perspective, whilst we're doing the planning of the place plan for next year, we have just stepped down the meeting in public the last time just to explore that thinking more. So there won't be minutes at the next.
Okay, now I get that. I understand that. Okay, thank you for that. Okay, before I close the meeting, this is our last meeting here. Because we're moving out of the building by the end of the month. We are looking at exactly where we would place them. We hope to be able to hold them in the fire service building, but we're still looking at some mechanics around that. But the future meetings will not be here. Okay, there is no private meeting, so that's the end of the business. Thank you very much, everybody. Before 12:30. 6 minutes. 6 minutes. 6 minutes in my life back. They all look at each other.